Today marks the final day in our three-part series of continuing medical education lectures. So without further ado, I just want to welcome you all and to introduce our chairperson for today's session, Dr. Alafia Stevens. Dr. Stevens is the president of the Medical Association of Antigua and Barbuda. Thank you.
Good morning, everyone. Thank you all for being here this morning. It's my pleasure to assist in chairing today's CME session. I'd like to commend the Medical Benefits Formulary Committee for taking the initiative to initiate such a exciting CME session. For those of you who would have missed the first two sessions, you are able to view those previous sessions via the Formulary Committee YouTube page. Today will be our third session with one of our very own, Dr. Gaydon Osborne. So Dr. Gaydon Osborne is stationed here in Antigua and Barbuda. He is a graduate of the American International College of Arts and Sciences in 2008. In 2013, he graduated from the American University of Antigua College of Medicine, obtaining a Doctor of Medicine. He continued on to complete his internship at the Albany Medical Center, Department of Internal Medicine in 2015. And he didn't stop there. He continued on to complete his residency in Albany Medical Center, Department of Urology in 2018, and completed a fellowship in clinical neurophysiology, epilepsy, University of Michigan in 2019. Dr. Gaydon Osborne joined the staff of the Sir Lester Bird Medical Center, formerly Mount St. John's Medical Center, in October of 2020, and is still employed and doing a lot of hard work as our consultant neurologist at our lone hospital in our country here in Antigua and Barbuda. So please help me in welcoming Dr. Gaydon Osborne, consultant neurologist. Dr. Osborne.
Hello, good morning, everyone. Thank you so much for your patience. Alafia, thank you so much for that wonderful introduction. I'm just going to go right ahead and share my screen. Can everyone see?
Yes, we can.
Okay, very good. All right, so I've been charged with presenting two topics today. The first one is the management of Parkinson disease, which can be a Herculean task because you actually need an entire movement disorders fellowship to truly understand this, but I'll do my best. One of the things I'll be focusing on is to shamelessly put a plug for MBS because I think the whole MBS team is really underappreciated, and as so many of my colleagues have mentioned in their interviews, the medical benefit scheme has done so much for Antigua for the diseases that they do cover. And it's not until patients travel abroad and they get hospital bills, they realize exactly, how important the medical benefit scheme is to Antigua. I'm actually going to turn off my video for better streaming. I'm going to try to get some of these things off the screen and then we'll start. There we go. All right. So I have no disclosures. Today we'll go through a brief introduction, a brief history. We'll speak about some epidemiology, some pathophys, the clinical symptoms, and then I'll get into the meat of the matter with talking about the medications and the treatment of motor symptoms and non-motor symptoms. And then we'll talk about some fun stuff, right? Diet and nutrition, right? So today, I want you guys to wrap your head around the concept that there's idiopathic Parkinson disease, and there is drug-induced Parkinson disease. There's also atypical Parkinson disease, the so-called multiple systems atrophy, the progressive supranuclear palsy, the cortical basal ganglionic degeneration, dementia with Lewy bodies. Today, my focus will be on idiopathic Parkinson disease. So what is Parkinson's disease? It is a chronic progressive disabling neurodegenerative disorder. That is to say, brain cells degenerate, they lose their connections, they shrink. The networking that is so robust in the younger age, the younger brain, is now frail, and hence with the disconnections and new connections, you have the emergence of motor symptoms as well as non-motor symptoms. And it is quite common. It is the most common disorder, second to Alzheimer's disease. So it was not until my fourth year of medical school when I was introduced to this wonderful piece of work called the Essay on the Shaking Palsy, written by a UK physician who in his practice saw 3 patients as well as persons that he just observed in the streets, and very, very astutely described the features of Parkinson's disease, both motor and non-motor features. And we'll get into that a little bit more. While on the interview trail during my fourth year, this is when we interviewed for residency, one of my first interviews was at the University of Missouri, in Columbia, Missouri, nice little town. And it was there that I met with a program director who was actually a behavioral neurologist, Dr. Joel Schenker, who introduced me to this wonderful piece of work. And he stressed that, in medicine, specifically, especially neurology, we really need to understand the phenomenology of diseases, okay? It's not enough to just know the basic sciences or know, what treatments are available and, how to treat diseases, but you need to know, okay, a patient is coming in, what stage of the disease is this patient in at this current time? What's next? If I do this medication, what sort of features I see next? What do I do? What do I inform the patients and families about? What to expect? And this is really important. And this is a concept called phenomenology, and it is important for almost every single disease that we treat. So as I mentioned, in 1817, James Parkinson wrote this monograph, an essay on the shaken palsy. And at that time, it didn't have a name, but he called it paralysis agitans. Agitans denote the shaking that was prominent in patients with this disease, and paralysis because there was weakness that accompanied the shaking. He also noted how progressive the symptoms were. But then Jean-Marie Charcot, who is noted to be the father of neurology, later added rigidity and bradykinesia, which are key features in this disease, and he paid homage to James Parkinson by calling it Parkinson's disease. It was not until the 1950s when Dr. Carlson discovered that levodopa could reverse reserpine-induced akinesia, and then almost 2 decades later, co-authors and colleagues discovered that levodopa improved the symptoms of Parkinson's disease. So a little bit about the epidemiology. In the US, an estimated 1% of patients over 60 are affected by Parkinson's disease. I don't want you to disregard this, but I'm going to say this, please take this with a grain of salt, because it says affected by Parkinson's, and it's not just the patient, it is the healthcare system. Every year, billions and billions of dollars are dumped into the healthcare system to cover office visits and medications and insurance paperwork and operating theater fees and fees for the surgeons and fees for the devices. And then outside of the financial burden on the system, there is also caretaker burden. I mean, imagine you are the wife of a person with Parkinson's disease, they can't work, you may have to retire early in order to take care of the patient. You know, walking in town, there's freezing of gait, and everything is slow and you can't get along with your life as quickly as you could have before. And then later in disease, there are falls. You have to help to prevent falls with these patients. And there's the hip fractures and the subdural hematomas, and more stress on the medical system because there's admissions for aspiration pneumonia. Again, this antibiotics, this is just a huge burden overall. And then, this urinary incontinence, fecal incontinence or constipation, where the caretaker may have to do fecal disimpaction manually, which may not be the most favorable thing. So overall, it takes a toll on persons taking care of persons with the disease, as well as the person who is directly affected with the disease, as well as all other caretakers and the medical system. So the lifetime risk of Parkinson's disease is about 2% in men and 1.3% in women who are over 40. The incidence of the disease prior to 50 is low, but it increases with age and is about 13 in 100,000 individuals, right? And no area of the world is immune to Parkinson's, as we all know. So we know this from medical school that the main neuropathology in Parkinson's is the loss of dopaminergic neurons in the substantia nigra, all right, specifically the pars compacta. This dopamine depletion affects the nigrostriatal pathways. The substantia nigra has connections. Remember, we spoke about networks. They're networks, they're huge networks that connect to the putamen and the caudate. You remember from your basic sciences that putamen and caudate make up the striatum, all right? And there's so many factors that contribute to the motor and the sensory symptoms of Parkinson's that it may be a little bit much to get into right now. Remember also, in addition to the motor symptoms, there are non-motor symptoms, some of which are neuropsychiatric. And if you didn't remember, I'm going to remind you that the anterior basal ganglia and the anterior subcortical region has a huge role to play in emotions and memory and the whole psyche, so to speak. There are huge connections within the limbic system in the PAPE circuit. I hope I'm triggering happy memories of basic science. There's also connections to the nucleus basalis of Meniere, which is responsible for acetylcholine production. There's also the nucleus accumbens, where the putamen and caudate join in the ventral surface of the brain via these small spiky neurons, all right? And you have to think about reward systems from the nucleus accumbens. And with these reward systems, it triggers certain behaviors. For example, you drink a Coke and you feel good after, and you seek that feeling again. You do skydiving and it's an exhilarating feeling, although it's scary, but you seek that behavior again. In Parkinson, these neurons and these connections degenerate, okay? And with degeneration, you have the lack of enjoyment of certain activities that you previously enjoyed. So there's depression, there's apathy. You just don't want to do anything. You don't want to seek fun behavior. So there's anhedonia. And there's so many other things that we'll talk about a little later on that have to do with this dreaded disease, all right? So by the time patients become symptomatic, you already have depletion of about 80% of the striatal dopamine content. And it's believed that the actual disease, this neuropathologic process, predates the onset of motor manifestations, which is estimated to be about 4.5 to 5 years. And here's a demonstration. To the left of your screen, there it demonstrates the normal connections of the nigrostriatal pathway. If you look at the bottom, this is a section of the mesencephalon or the midbrain, where the arrows point. This is your substantia nigra pars compacta. If you notice, it's a little bit dark, and that's where it gets its name from, the nigrostriatal pathway. And these connections go through the entirety of the subcortical region to the putamen and caudate in a lovely fashion. On the right, you see depletion of these dopaminergic neurons, and the area which was previously dark is now a bit lightened. And hence there's disruption of the natural networks, and hence you have motor symptoms and non-motor symptoms. One of the hallmarks in terms of neuropathology for Parkinson's disease is misfolded alpha-synuclein and ubiquitin, and these form Lewy bodies. And Lewy bodies tend to be distributed throughout the brainstem and contribute to the motor symptoms. If you guys remember, one of the neurodegenerative diseases is dementia with Lewy bodies, and one prominent feature of dementia with Lewy bodies is Parkinsonism. All right. So we've spoken so much about the dopamine and dopaminergic neurons already. I just want to keep in mind and to remind you that there are other pathways that are involved and other neurotransmitters involved in Parkinson's disease, particularly the locus ceruleus that produces norepinephrine. And, you know, when we're treating depression, we try to inhibit the reuptake of norepinephrine, and if you're depleted, then it kind of explains the non-motor symptom of depression. Also, their autonomic dysfunction. So some patients tend to have an orthostatic hypertension. This is mostly seen, however, or more prominent in multiple system atrophy, which I promise will not talk about. It's a bit much for this presentation in just 1 hour. Next is the raphe nucleus, or the midbrain raphe, that produces serotonin, again, the feel-good hormone. If you lose that, you're going to be depressed. And I've spoken already about the nucleus basalis of mania that produces acetylcholine. So some disabling symptoms also include the cognitive impairment. Postural instability is huge because falls are a common reason for neurology consultation. Many of the referrals I get over patients who have frequent falls, and physicians, they're onto something. They really do think that there's a neuropathy or there's Parkinson, but they just want confirmation, and and that's appreciated. I can more than appreciate that, and it's appropriate to refer to me at this time, at any point in time when you have a Parkinson patient for that matter. I really don't mind. Constipation may not necessarily be explained by the loss of dopaminergic neurons, but it's definitely something that happens as well. So clinical manifestations. So before the motor symptoms start, you have pre-motor symptoms, constipation. So there's a school of thought that believes that Parkinson's disease originates in the gut, and there may be some sort of environmental factor that triggers some loss of a gene mutation or something of this sort, which later results in the accumulation of Lewy bodies, a loss of dopaminergic neurons in the substantia nigra, and the progression of Parkinson's disease. Anosmia, any neurodegenerative syndrome that affects the basal ganglia or the forebrain will result in anosmia. Remember, the entorhinal pathway starts from the forebrain and it projects through the basal ganglia through the temporal lobe to sense smells. So if these networks and the cortex degenerates, then you will have a change in your sense of smell. Again, we've spoken about depression, REM sleep behavior disorder. This is something that you see in the alpha-synucleinopathies, specifically Parkinson's. You'll see it in dementia with Lewy bodies, and you'll see it in multiple system atrophy. REM sleep behavior disorder is essentially acting out your dreams, and sometimes the dreams become violent and the bed partner can be hurt. When patients come to the clinic, it's important to ask about these premotor symptoms, especially if your suspicion of Parkinson's is not that great. these symptoms may help you to kind of, rope things in a little bit better and make a better clinical judgment. And here are the non-motor symptoms separated into 5 categories. There's the neuropsychiatric. So you have depression, and with depression comes anxiety. We spoke about apathy, anhedonia, abulia, amotivation, but there are also hallucinations. So hallucinations can happen as a result of the medications or as a result of the natural disease progression. Okay, the hallucinations in persons with Parkinson's are usually non-threatening. One frequent hallucination is a patient seeing little children in the outside environment or in their room, and it's actually a happy hallucination, and they know that it's not threatening, and they know that it's not real. And sometimes that's the difference. That's telling the difference between hallucinations due to Parkinson's versus hallucinations due to other psychotic disorders such as schizophrenia. There are also panic attacks. Of course, there's cognitive dysfunction with memory loss and dementia. There's autonomic dysfunction. We spoke about orthostatic hypotension. We spoke about constipation. There is drooling or sialorrhea. You see a lot of that in patients, and it's important to ask these questions because there comes the onset of dysphagia. What's also important is the urinary incontinence or the urinary urgency. Sexual dysfunction is really important. And, I really wish I could speak about this a little bit more. It's really more suitable for my urology colleagues, Dr. Rudd, Dr. Thwaites, and Dr. Johnson. Hopefully sometime in the future, maybe we can do a joint CME to talk about sexual dysfunction and neurodegenerative diseases because it's a hot topic. There's also altered cardiac defects, there's GI dysfunction, increased sweating. We all know that there's sleep disorders. Sleep disorders are common in the general population, let alone patients with neurodegenerative disorders. So there's insomnia. You also have to deal with somnolence and excessive daytime sleepiness. Some patients can have restless leg syndrome or periodic limb movements of sleep. We mentioned about the REM sleep behavior disorder, as well as vivid dreaming. Now, there's some medications that we'll see that also cause sleep attacks. And that's important to counsel patients about, especially if they have a profession where they cannot afford to fall asleep, like if they're a school bus driver, okay? Sensory abnormalities, there's AGC, loss of taste, anosmia, there's numbness, paresthesias, and pain. Pain is so important to address because, it really makes a difference in quality of life. If someone is having pain to the point that it's debilitating, then, the quality of life is actually poor. So the classic motor symptoms, you remember from your studies that there's a mnemonic called TRAP, all right? It stands for tremor. So the tremor of Parkinson's disease is a slow tremor. And it's usually at rest, but can also be with action, all right? Some persons have described it as a pill rolling tremor because of the way the fingers are approximated. There's also rigidity, which is a resistance to passive motion. So you try to flex the patient's arms or legs and you feel this resistance. You would remember the terms lead pipe rigidity, where there's a constant resistance to the motion, as well as cogwheel rigidity, which is same thing, but there's a superimposed tremor, so it kind of stops. Right? There is also akinesia or bradykinesia, which is slowness of initiating movement and continuing movement. So they come to the clinic and you ask them to do the finger taps, and you see that, number one, they may not be able to do it as quickly as you can. The amplitude of exertion between the tip of the index finger and the tip of the thumb tends to be shortened with continuous movement. So they may start off with a large motion and then very soon it's a fine tap, okay? Akinesia, you also will see, or bradykinesia, you also see with your micrographia. That's actually a form of bradykinesia. And micrographia does not mean necessarily that you just have small handwriting, right? Because many of us have a small handwriting. Micrographia really suggests that you start one size And gradually the handwriting gets smaller and smaller to the point that it is illegible. And you know how important this is? Persons with Parkinson's disease can sometimes they can't even sign a check, cannot even sign a check, and that's a huge deal. Later in disease, there's postural instability because of balance dysfunction. Okay, there's something that I do during my movement exam called a pull test or retropulsion. You ask the patient to stand up and make sure they're steady. You tell them, listen, I'm going to give you a small tug. You try to not fall. And most patients who already exhibit postural instability, you tug the shoulders backward. You have to be behind them in order so to catch them in the event that they fall. But most persons will take several steps back, and some will just fall right away. This is an important sign. There's secondary motor symptoms. There's reduced arm strength, arm swing. So if you notice when persons with Parkinsonism walk, they're not swinging one or both arms. When you speak with them, there's a decreased blink rate, right? Some of us blink maybe a few times per minute, but patients with Parkinson's, they will have this stare, almost scary sometimes. There's also hypomimia or mass faces that you've heard of. There's hypophonia, it's a change in voice. The voice becomes either husky or really soft. And some patients also have difficulty with turning over in bed. So this is a picture from the cover of the book, an essay on the shaken palsy. So let's, dive into this. You look at this gentleman. So you have a view of him from the side. If you realize he has this stooped posture, notice there's a sort of kyphotic posture being assumed, and the head is down. I don't know if you can appreciate that his eyes are, wide open. Look at the knees. The knees are slightly bent. The arms are flexed at the elbows, and pay close attention to the hands. The hands tend to assume what we call a sandwich posture, where the digits 2 through 5 are somewhat closely approximated, and then the thumb is abducted, assuming a posture as if you're actually holding a sandwich while walking. Okay, this is really important. The image to the right, you can see, I don't know if you can appreciate it, but he's slightly twisted, so to speak, to the right side, as well as the stoop posture. And this is something called camptocormia. This is a posture that is frequently recognized in Parkinson's disease. All right. Another thing to speak about is the gait. Things that are important are, can the patient rise from a chair without using their hands? What is their station? Are they broad-based, narrow-based? Now, their stride, how is their stride length? Okay, how is their heel strike? Because walking essentially is standing on one leg and then standing on the other and doing that in succession to move along in locomotion. All right. Patients tend to not have a good heel strike and to have a short stride length, resulting in the classic shuffling gait. All right. Now, sometimes balance is lost and patients tend to move forward very quickly in order to maintain the balance, and that's called festination. Okay, so I really hope everything is coming together right now. So for the typical office visit here at the Celeste Bird Medical Center, patient comes in, there's registration and vitals, and then our assistant, Janella Jarvis, does a PHQ-9, which is a questionnaire used to identify persons at risk for severe depression. All right, so we kind of risk stratify into mild and severe, and for those who are at risk, we provide intervention, which includes counseling as well as antidepressants if needed. All right. The patient then comes over to my room where I take a detailed history. I ask about the premotor symptoms, which include constipation and nausea. I say, listen, are you able to smell your meals as well as you used to? Or when you walk into a perfume shop, are you really smelling these scents as strongly as you used to? And you'll be surprised about how many persons say, listen, you're right. Never really spoke about it, but I don't smell things as well as I used to. Constipation. Um, a lot of persons do have constipation, but then, the general population also suffers from constipation a lot, especially if they're not eating enough fiber. And I move on to the general physical examination. So not because you're a neurologist, you skip the heart exam, lung exam, the abdominal examination, the extremities, the pulses, etc. You must do that. And then you move on to the general neurologic examination, and then the movement exam, looking for bradykinesia, feeling for rigidity, observing the tremor, distracting them to see if the tremor and rigidity is distractible, asking them to stretch their hands out, close their eyes, and count from 100 backwards and see if there's a re-emergent tremor. You also have to evaluate if the tremor is asymmetric. If the symptoms are asymmetric, that's important because if the Parkinson symptoms start fairly symmetric and in a person around age 50, you want to entertain the diagnosis of atypical Parkinson. Okay? And then there's the pull test that we spoke about, the posture to look for postural instability, and then there's the gait exam. After the exam is done, I render my opinion and we start to talk about treatment, and I counsel them on disease and, again, phenomenology, what's next. So there's some terms that I need to clearly define before I jump into medications. Dyskinesia. So this is an abnormal involuntary choreiform movement. It's a dance-like riding type of movement that affects the head, the limbs, and the torso. And it can be induced by levodopa, and it may also manifest as myoclonus, dystonia, ballism, which is a wide amplitude motion, or it can be a combination of all of these together. There's dystonia, which is an involuntary prolonged muscle contraction with abnormal posturing that usually affects the limbs. So you have contraction of both agonist and antagonistic muscles, and that is very disabling sometimes. Right? Dystonia usually occurs with lower dopamine levels, that is to say the off periods. It can also happen early in the morning when your evening dose has worn off. You'll hear the term motor fluctuations being thrown around, and this is usually for more advanced disease. So this refers to off times. These are periods when there's a poor response to levodopa, and on time. This is when your medication kicks in and there's improved function and you feel really good about yourself. There's freezing. So freezing is defined as an episodic inability to move, and this lasts a couple of seconds, and it usually happens when patients are changing direction or they're walking normally and they have different stimuli coming in. Persons talking to them, persons passing them on the street, cars passing them, they have freezing of gait. So this doesn't only happen in Parkinsonism, it also happens in other disorders, one of which is your normal pressure hydrocephalus. All right, so let's talk about some agents, and throughout the presentation, I will highlight what the MBS offers, okay? I think that's the real gist of these presentations, to really highlight that medical benefits has done so well with their formulary and now offers so much more to patients. So the prototype drug, levodopa, is the gold standard for dopamine replacement in Parkinson's. You usually combine it with carbidopa, which is a decarboxylase inhibitor to reduce the peripheral breakdown and lessen the nausea. All right. I feel one of the most brilliant names for carbidopa, for a medication is this carbidopa levodopa, Sinemet. Okay, sin, sign, meaning without, emet, meaning emesis, and you put them together, it's without vomiting. Okay, I think that's brilliant. It's available in immediate release, control release, and oral disintegrating tabs. For the MBS, they carry the 10-100 combination and the 25-250 combination of the immediate release. Unfortunately, the control release and the oral disintegrating tabs are not yet available. I'm hoping this could be a possibility in the future, but we'll just have to see. I am really accustomed to the 25-100 during my training because, you know, the higher proportion of the carbidopa, the less likely the peripheral breakdown and the less nausea the patients experience. So that's really the combination that I'm used to, but I've been rocking out with the 10-100 and the 25-250. There's also Rytary, which is also carbidopa levodopa, but it's absorbed a little more rapidly. And it's used to help to prevent the troublesome dyskinesias and reduce off times. Most recently, the FDA has approved Inbrija, which is an inhaled levodopa. And this is awesome because, you know, sometimes there are off times and, you know, you just ask the patient to, you know, take a whiff of their inhaled powder and it reduces the off time significantly. Now, for more advanced patients, there is the intestinal gel, and this is to be administered via a PEG tube. It reduces off times as well as the dyskinesias. It has a more constant sort of absorption and release into the system. And again, it's ideal for patients who cannot be optimally treated with oral medications, maybe because of dysphagia and risk of aspiration, or, you know, other side effects from oral meds that they cannot tolerate. Next up are the dopamine agonists. And these directly stimulate the dopamine receptors, hence you bypass the substantia nigra and the nigrostriatal pathway. You're no longer dependent on the dopaminergic neurons in the brain. You're stimulating the receptors directly. They can be used in monotherapy or adjunctive. The half-life is a little bit longer than levodopa, approximately 6 hours, where the half-life of levodopa is about 1.5 hours. So think about it. If levodopa's half-life is an hour and a half, you need by the time 5 half-lives, you have that completely out of your system. That's about 7 hours. Okay. This is why we need to dose it so frequently and not just once a day like I've seen. The dopamine agonist is there's a higher incidence of the psychiatric effects. So the hallucinations, the impulse control disorders. So when the patient comes into you, you have to counsel them on the possibility of impulse control disorders, okay? Persons who have been very careful with their spending suddenly turn to huge investments that make no sense and you wonder why, or they turn to gambling. You know, some persons indulge in risky behaviors such as skydiving. There's also pornography. So it, you know, it can also affect marriages. Okay, so, you know, a woman would be, you know, wondering, you know, what is wrong with my husband? You know, he's not really paying attention to me. There's something going on. And he is just stuck behind a computer screen on a particular website that's just not good. There are also sleep attacks. Okay, and these are just sudden urges to sleep, and sometimes you just cannot fight the urge and you fall asleep. Now, this is also important to encourage to counsel your patients on, because, you know, if a patient happens to be a school bus driver or has some job that falling asleep will result in bodily harm, detriment, or death, you really have to counsel them on this. So the dopamine agonists are ropinirole. This is available in immediate release and extended release formulations. MBS provides the 8 milligram extended release tabs. There's also 0.25, 1 milligram, 2 milligram, that should be 3 milligrams, not 3 grams. That's a whole lot. And 6 milligram tabs. There's also pramipexole. We also carry that in several different dosage amounts. There's also an ER tab at 3 milligrams. Rotigotine, unfortunately, we don't have. This is a transdermal formulation, so you put the patch on for 24 hours. There's also apomorphine. We also do not have this, and this is subcutaneous rescue during the off periods. All right, making our way down. COMT inhibitors. So this class of drug reduces the breakdown of levodopa to 3-O-methyl-dopa, and hence increases the half-life, and it's given with every dose of dopamine, of levodopa, sorry. The problem with it is that it may increase the dopamine-induced, the levodopa-induced dyskinesias. The medications that we learned about in school are entacapone and tolcapone. Tolcapone carries a black box warning for potential liver toxicity, so we don't use it. I've actually never used it. What we use is entacapone, 200 milligram tabs, and you take it with every dose of levodopa, carbidopa levodopa. And yes, MBS does provide this. There's also a new medication, Ongentys or opicapone, just recently approved by the FDA. And it does really well reducing the off time by approximately 30 to 60 minutes. So you may say 30 to 60 minutes, but that's not any time compared to the 24-hour day. But yes, it is. Can you imagine what you can do in 30, 60 minutes? You can have a card game with your grandchild. You can possibly take them to school if the school is close enough. You can make breakfast for your family. There's so many things you can do. You can shower on your own, dress on your own during that on period, okay? So opicapone does really well at reducing the off time. So the MOB inhibitors that prevent breakdown of levodopa in the brain and also limit its reuptake. 3 of them that we know of is salicyline, which is approved for adjunctive therapies given twice daily, available in 5 milligram tabs. And there's rasagiline, which can be used as both mono or adjunctive therapy. There's also safinamide. I haven't used this much at all, but it's a fairly good drug. And yes, MBS provides salicyline. So if your patients are not tolerating carbidopa levodopa, or you feel like there's just something else that needs to be done and you need help, you can call me and we talk about adding salicyline, or you can just send the patient to the clinic and we talk about the salicyline. All right, amantadine. So this is an old drug previously used as an antiviral agent in the 60s. And what physicians noticed is that persons who had Parkinson's disease and had the dyskinesias, who were treated with amantadine had resolution of their dyskinesia. So then it started to be used for treating the troublesome dyskinesias. There's also a newer preparation, which is extended release, and it works really well. Unfortunately, to the best of my knowledge, we do not offer amantadine. There are also the anticholinergic medications. Remember, we spoke about the different neurotransmitters other than dopamine involved in Parkinson. So there's trihexyphenidyl and benztropine, both of which are available. This is preferred in tremor-predominant Parkinson's, really good for treating the tremor Parkinson's, especially if it's disabling. So think of someone trying to hold a bottle of water or trying to feed themselves, and the tremor is just not allowing for that. Or even for, for the social graces, you're at dinner and you're really worried about, having this tremor, around your friends and family, and, these medications significantly reduce tremor in concert with levodopa, so it really improves the quality of life. I typically do not treat older patients, that is to say patients greater than 70 years, with these medications because of their strong anticholinergic effects. It can cause confusion in the elderly, which is not favorable. These patients can have some really bad hyperactive delirium. Sorry, cap is going off. These patients can have some really bad hyperactive delirium, which can be debilitating. There's also dry mouth and urinary retention and constipation. And someone who's already constipated, anticholinergic drugs can exacerbate this. All right. So as of now, the treatment of early Parkinson's, there's no benefit in withholding treatment in patients who have symptoms. So when someone comes to your office, you need to determine, number one, do they have symptoms? Number two, are the symptoms debilitating? Okay, and you make your decision on whether or not you're going to start therapy from there. There was a school of thought, a very old school of thought, where they thought that if you use levodopa early, you will lose the effect early, and if you spare levodopa and start it later on, then patients may do a little bit better. But we now know that that is absolutely false. That is not true at all. As a matter of fact, the reduced response for levodopa comes from progression, sorry, of the disease. Okay. Also, non-motor symptoms, as we mentioned, should always be kept in mind. So again, factors to consider: age. If they're young, you may want to start a dopamine agonist such as ropinirole. You may want to do rasagiline, or you may want, if the Parkinson's is mild and it's just tremor predominant, you may want to just do a trihexyphenidyl or benztropine. Consider comorbid conditions. Think about if they are hypertensive, think about if they have orthostatic hypotension, think about diabetes and all the other comorbidities that come along. Think about the employment status. Are they working or not? Will they be able to break and take their medications? And then other qualities like this should be considered. And, this is something that you should do for every single patient, not just patients with Parkinson's. So the timing of levodopa administration is important. And for those of you at MBS who have seen my prescriptions for carbidopa, levodopa, you will realize that I always state very clearly which tab I want, whether it's 10-100 or 25-250. I will tell you how many tabs I want and at what times I want them, okay? And this is really important because later down, the patient will be making a diary and explaining to you, when they're having the motor fluctuations, when the medication stops working for their symptoms, and when it kicks in, and when are the troublesome dyskinesias. And based on that, you adjust your time intervals and you adjust your dosing. Okay. Pulsatile doses can contribute to dyskinesias, and that's a little bit obvious. One of the things that's done at every university program, and that includes the ones that I was trained at, is that they do a video, okay? There are video files that are kept for patients with movement disorders. The videos are done for education purposes. They're also done to look at the response to, an objective response to medication and progression of the disease. And it's something that I want to start doing, for my clinic patients. I'm just hoping that, the next budget roll around, they can sponsor a camera for the neurology department. If not, I'll just get it myself, and, we'll get the ball rolling with this. Yeah, so dopamine agonists, when you're starting dopamine agonists, usually do it in patients younger than 70. Again, you need to counsel patients on the impulse control, all right? And, and sometimes you really do have to think about whether or not, what sort of employment the patient has. You don't really want to give a pastor with Parkinson's ropinirole because, there may be some risky behaviors that may go against the religion, okay? Always important to monitor and counsel for sleep attacks like we spoke of. But one thing to take great note of is that eventually the non-levodopa medications will not be enough for controlling the symptoms, and you'll have to use carbidopa levodopa anyway. Option, again, is selegiline or rasagiline, the MOB inhibitors. The anticholinergics, as we spoke about, were for tremor-predominant Parkinson's. I know I keep repeating a lot of these things, but repetition is the key to pedagogic learning. And I hope that at the end of this, you guys really have a grasp of how to treat this disease. So again, remember the side effects of urinary retention and confusion. I'm really concerned about confusion in the elderly, so I don't start anticholinergics if the patient is over 70. Exercise is really important. You guys see the media, you guys see Michael J. Fox, and you've seen when Muhammad Ali was alive, and you've heard of persons who do really well with cycling and yoga and boxing. There's also dance and music therapy. There is nothing in the world like music, I'm telling you. It works really well for degenerative diseases, especially Alzheimer's. Um, I specifically remember, and I'm sorry for this anecdote, but it's not pointless. I specifically remember at one of my uncle's funerals, my grandmother, she was already suffering from Alzheimer's and really bad memory loss. And there was a song that was sung at the graveside, and she sang it with such vigor, and there was not a single word or tone that was left, and that struck me. And it's not until now I kind of understand these things, how music affects the brain, etc. Okay, so there's that. But yes, aerobic exercise is really important. Sometimes you may find that during boxing sessions and during cycling, the patient may appear as though they don't even have Parkinson's disease. And the moment they stop, they go right back to being rigid, having a stoop posture, and having the bradykinesia. Cognition is really important, and cognitive training is good. Usually tell patients, do some Sudoku, do some computer games. Also encourage good social interaction like any other dementia. Now, for the management of advanced Parkinson's disease, you just have to appreciate that there will be motor fluctuations, and there will be levodopa-induced dyskinesias, and you have to be sophisticated with your medication adjustment in order to address these. It's really important for the patient and the family members to work with you to provide this diary so that you can really hone in on, when these things happen and how to address them. Sometimes wearing off can be predictable, but sometimes it's also somewhat diphasic and unpredictable. What causes the motor fluctuations? The natural progression of the disease, phenomenology. Right? There's also the short half-life of levodopa, and with that, there can also be fluctuating plasma levels in response to the oral doses. The gastric emptying can be a bit erratic in patients with advanced disease. And then there's competition for absorption with levodopa and amino acids. So sometimes we tell patients to take their medications about 30 minutes before the next meal. Okay? And that kind of helps the absorption and the transport across the blood-brain barrier. The aim of treatment is to optimize the on time, reduce the off time, and minimize the dyskinesias. Okay, the off times can be managed by, number one, you can increase the dose. So you can do a tablet and a half, or 2 tablets, or 3 tablets as tolerated by the patient. You can switch to an extended release form. Unfortunately, we don't have that just yet. You can add entacapone, a COMT inhibitor. You can add selegiline to the MAOB inhibitor, or you can add a dopamine agonist. Try not to necessarily do this in the elderly unless you're doing apomorphine, which is the subcutaneous formulation. Or you can do the intestinal gel. So treatment of the dyskinesias requires identifying the occurrence in relation to the dosing of levodopa. So some of the strategies that you can employ are, again, redistributing the medication. So, you can dose levodopa as frequently as every 2 hours. Sometimes you may want to do, 2.5 or 3 hours if the patient is experiencing the dyskinesias, depending on what you're treating them before. You can add amantadine, or you can switch to the intestinal gel that we spoke of before. And this is especially good for patients who have just been suboptimally treated or patients who have dysphagia. There's also surgical management. Okay, so there's DBS, it's a hot topic and it's really fun. It's a programmable procedure, meaning once the leads and the generator, and you can adjust your settings according to the patient response. Patient selection is important. You have to select patients who would do well with it. An accurate implantation. So you have to have an astute functional neurosurgeon as well as a well-trained movement disorder specialist to pre-plan all of this and plan the trajectories and plan which neurons you want to listen to in the subcortical regions to target the specific symptoms. And you also have to stay away from certain areas that may produce depression with suicidality or other unwanted signs and symptoms. So most persons with DBS tend to get it with, after 10 years of diagnosis, but there's a trial called the Early Stim, which suggested that the earlier the better. All right, there's some exclusionary criteria, and that's one, atypical Parkinsonism, so you have to have your diagnosis correct. Unstable psychiatric disease, you really should not have a DBS. Advanced disease with significant dementia. I mean, at that point, you really need to evaluate the quality of life. And, sometimes, doing a DBS may not make sense. And, these patients may be more suitable for a skilled nursing facility or hospice. Also have to consider comorbidities that may preclude surgical candidacy, such as stroke in regions that you would want to stimulate, such as tumors, etc. And then advanced age is something to take into consideration. So during the workup, much like the epilepsy surgical workups, you have a neuropsychiatric evaluation. Your risk of cognitive impairment is assessed. You have to have medical clearance. You also do MRIs as well as CT angiograms to not only look for strokes, but evaluate for cerebral volume loss. Remember, neurodegenerative, these cells, these networks are going to shrink and lose connection, and then other abnormalities that can interfere with lead placement. So again, preoperative imaging, the targets I identified. Most common targets include the subthalamic nucleus, the globus pallidus internus, and the ventral intermediate nucleus of the thalamus. And this is more so for predominant, tremor predominant, with minimal otherwise symptoms. The trajectory is planned, and the reason for this is that you need to avoid vascular and other important structures, all right? And these are some pictures from the software and from someone in the EOR having a DBS place. These are some more pictures with the trajectory being done. If you look at those lines, that's the exact trajectory. You miss vital structures and you also miss the blood vessels, so you don't cause a stroke, and you hit your target. You listen to the neurons, they actually make us, a kind of weird high-pitched sound. And based on the sounds, we like to think of it as the neurons talking to one another. You can determine the actual symptoms and the response to treatment and whether or not you're in the right place. Okay, so this is some really good stuff, and this is where neurology really comes to life. Right here at Mount St. John, we are just scraping the surface, I'm telling you. Right, this is an example of a Boston Scientific device. So they're doing a lot more things with these nowadays, and soon they will have closed loop systems that not only you can place them and make your necessary adjustments, but it can also read data and adjust itself based on the symptoms that the patient tend to have, specifically off times and the dyskinesias and the bradykinesia. And I think this is awesome. All right, so some complications of DBS include MI, pneumonia, DVT and PE. Then there's surgical issues such as hematoma, strokes, seizures, infections, heart rate dysfunction. Again, this is rare. Side effects include paresthesias, dysarthria, ataxia, and mood dysregulation. So let's talk about some non-motor symptoms and their treatment. So some of the non-motor symptoms just require some levodopa because they occur during the off periods. And if they do occur during the off periods, they're more likely to respond to levodopa, whereas others are a lot more difficult to deal with because they occur at any time. So the mood disorders, you can see depression and anxiety. They may respond to levodopa, as I mentioned, in the off periods. Highly consider the tricyclic antidepressants, keeping in mind that there is a high anticholinergic effect, and you may not want to do this in the elderly. medical benefit has amitriptyline. Also the SSRIs, paroxetine and citalopram. I think we do carry paroxetine. I'm not 100% sure on that, but I'm pretty sure I've prescribed paroxetine for patients. There's also the SNRIs, venlafaxine and duloxetine. Pramipexole, the dopamine agonist, can also work. And then for patients who also have anorexia, you can use mirtazapine, works really well. For psychosis, you may want to reduce your dopamine agonist if that's possible. But now you have to think about choosing an antipsychotic. And, there's a kind of catch-22 because you are trying to improve dopaminergic activity, but neuroleptics block dopamine activity, and hence they can worsen the signs and symptoms of Parkinson's disease. The two antipsychotics that are least likely to cause the worsening are clozapine, but then clozapine lowers its seizure threshold and it can cause agranulocytosis. And who wants to deal with that? So we do quetiapine, and quetiapine is available to MBS. A newer serotonin receptor antagonist is pimavanserin, and this works really well for patients who have these hallucinations. But it's also important when you're evaluating patients with these psychotic symptoms to exclude concomitant illnesses such as infections. Dementia, this is a neurodegenerative disease, so dementia is very possible. You need to do a workup for reversible causes, and then if you don't find anything, you may want to start one of these agents, rivastigmine or donepezil or memantine. Donepezil and memantine are available through MBS. All right, pain. So pain is a huge deal in Parkinson's. Anywhere from 35 to 60-something% of patients experience pain when they talk about this disease. So there's musculoskeletal pain from abnormal postures and the camptocormia that we spoke of, the stoop posture, the lateral deviation, the dystonias, scoliosis. These contribute to musculoskeletal pain. Again, there's pain from the dystonias, there's neuropathic pain. You can develop radiculopathies and neuropathies. There's pain from the akathisias, this restlessness that patients tend to have. There's GI pains from bloating. There's chest pain, there's GERD, constipation. There's also a central pain that happens that is believed to be due to basal ganglia networking, and this plays a huge role in the production of pain in Parkinson's. All right, so not 60-something, 85% of patients experience pain. So analgesics as well as the dopaminergic drugs can help during the off periods. Gabapentin can be used for the neuropathic pain. Baclofen can be used for the rigidity and the dystonias. Botox is also used for cramping and dystonias and contractures, as well as spasticity that, a patient with Parkinson's may end up having strokes, and, you treat spasticity with Botox. Amantadine can treat the dyskinesias, and pain comes with dyskinesia, so amantadine treats the pain of that. And then ask the patient to keep active if possible. I recommend physical therapy for all of my patients, and stress how important exercise is. I have one Parkinson patient, he is just awesome. I really wish he was listening to this, but he is just awesome. Plays football every Saturday morning, and just tries to keep really active, goes to the beach. Definitely one of my favorite patients. Drooling. All right, so there's also Botox injections for parotid and the submandibular glands. Unfortunately, we don't have that here to the best of my knowledge. You can use atropine drops or glycopyrrolate to help with the drooling. Then there's erectile dysfunction. This you need to do a psychological assessment. A urology referral is reasonable. And then you can think about the phosphodiesterase 5 inhibitors, keeping in mind that some patients may have orthostatic hypotension, and you don't want to do this if blood pressure is a problem. Insomnia, a huge problem in the general population, let alone patients with PD. Okay, one of the things to do is to encourage good sleep hygiene, have a ritual. So, every night before bed, you do the same thing over and over so that your brain kind of gets used to this. You shouldn't have your phone or laptop in your bed. And really, you shouldn't be watching TV or listening to the radio in your bedroom. Patients should avoid caffeine. Um, Melatonin is very reasonable. I've found that the lower doses don't really work. The 3 milligrams and 5 milligrams, they really don't work that well. So I just do 10 milligrams for patients. Hydroxyzine and amitriptyline for the younger patients with insomnia. These have uh, strong anticholinergic effects. Benzos are not my favorite. And when a patient is sent to me and I understand that they're on a benzo for sleep, I'm not very happy about it. Zolpidem and zolpiclone are other sleep aids. Ramelteon is an agonist at melatonin receptors, and it works extraordinarily well for sleep. And I'm hoping the pharmacies, especially medical benefit, can provide this in the future. It works really well for insomnia. Orthostatic hypotension, you need to make sure the patient is adequately hydrated. Prolonged bed rest should be avoided. Waist-high stockings can help. Patients can increase their salt intake. Bearing in mind, you have to keep the cardiovascular risk factors in mind. Midodrine is a reasonable option, as is fludrocortisone. All right, so let's talk about diet and nutrition. Coming down to the end. Some of the challenges faced by patients with PD are dysphagia, constipation, dysnosmia or anosmia, and dysgeusia, just loss of taste. Anorexia and weight loss are a problem, and again, orthostatic hypotension. So for low blood pressure, again, adequate hydration and free salt intake. For anosmia and dysgeusia, you need to, avoid smooth foods that are not going to really stimulate you. In foods that you're not too interested in, just avoid them. They're going to make you nauseous. You're not going to eat. Add spices such as turmeric and cinnamon, rosemary and ginger. For dysphagia, this is where the speech and language pathologist and the dietitian, really contribute big time to the treatment of these diseases, to recommend the appropriate diet. You need to modify food texture, lubricate the foods with sauces and oils, particularly olive oil. Reduce chewing requirements. You can chop and mince the foods. You can blend foods. Avoid dry, crunchy foods like nuts, especially when you're at advanced age. You can choke, you can aspirate. Use thickened liquids. And again, consultation with the dietitian and speech and language pathology. Constipation tends to be a problem. Again, adequate hydration, but more importantly, dietary fiber, with both soluble and insoluble fiber, right? And don't be afraid to mix it up. Your fruits, your veggies, whole grains and cereals, really important. Anorexia and weight loss. So, patients experience nausea, anorexia, this early satiety, slow gastric emptying. There's also increased energy requirements and more energy expenditure because of this rigidity, the cramping, and the abnormal postures. And way to treat this is to try to increase the intake. Use foods with high quality calories and proteins. Set a schedule, and have small frequent meals as opposed to try to use large meals at 3 times a day. You can do small meals 6 to 8 times a day. Also, you can use nutrition supplements, and again, consultation with your dietitian. So the best diet for Parkinson is actually the Mediterranean diet, and who wouldn't want to have that diet? I actually need to go on this diet. Wait for life, right? So there's some things that you should consume abundantly, some moderately, and some very rarely. Okay, so for abundant consumption, you can go ahead with, your fruits and veggies, your whole grains, your nuts if you're not allergic, and olive oil. For moderate consumption, fatty fish like salmon, sardines, herring, mackerel. You can do fermented dairy products such as yogurts and cheese. You can do eggs, poultry, and yes, wine. Low consumption, try to avoid the red meats and the processed meats and the refined sugars. Okay. So I hope you guys enjoyed that. In conclusion, I'd like to say that, Parkinson's disease is the second most common neurodegenerative disorder. We need to be aware of the premotor symptoms such as anosmia, constipation, and REM sleep behavior disorder. This helps with the diagnosis. A thorough examination is really important. You guys wonder why I can't knock out 20, 25 patients in a half day of neurology clinic. It's because I spend a lot of time examining patients and counseling patients. A video library is helpful. Best for teaching and monitoring progression of disease and response to treatment. The non-motor symptoms are not to be ignored because treating them can improve the quality of life. Surgical options are available in DBS. Exercise and cardiovascular health are important with any disease process for that matter. And then diet and nutrition are critical elements in the treatment of PD. With that, I'd like to say thank you very much for joining me. I hope this was helpful. Questions?
Thank you so much, Dr. Osborne, for that presentation. Quite informative. I'd just like to say you took us way back to Physiology 101, early years of medical school.
Yeah.
And I've told you this before, it takes a special mind to look at the brain and get excited at the brain with all of the different lights and colors for it to work. And I must commend you for the great job that you're doing presently at the Celeste Bird Medical Center and the amount of patients that you have to deal with at this time as our lone neurologist presently. So keep up the good work. At this time, we're going to take questions for Dr. Osborne. The initial question that we had in the question and answer segment from Dr. Zachariah. Her question was, read the shuffling gait. Do all patients have the ability to temporarily autocorrect if told to walk differently?
Oh, the simple answer to that is no, not at all. Not at all. As I said, when patients are doing certain activities like cycling or boxing, you'll realize that the rigidity and the bradykinesia goes away. And again, I don't have a perfectly, physiologic explanation for that. But it's a phenomenon that we encounter. In terms of the shuffling gait, you can't distract someone from a shuffling gait or a fascinating gait unless they're psychogenic. So bear in mind, they're functional neurological disorders, and very frequently in your office, maybe even 50% of the time, patients will present with psychogenic disorders, and you would have to do certain exam maneuvers to distract them or ask certain questions or observe certain things that will kind of hone you into the fact that, okay, this may be psychogenic, this patient may need some counseling, or this may just be functional at this time.
Thank you so much for that response. And we have another question. We have a few questions in the chat. The next question would be, what are the risk factors for Parkinson?
So risk factors include advanced age, the presence of other neurodegenerative disorders such as Alzheimer's. Interestingly enough, and I'm not saying to take this with a grain of salt, but don't go encourage your patients to smoke. I know you won't do that, but smoking was associated with a reduced risk of developing Parkinson's, and I'm not sure how that works. But yeah, smoking carries a reduced risk. Again, patients at advanced age and family history of neurodegenerative diseases, family history of Parkinson's. very rarely you can find Parkinson's disease in the young, meaning onset between 20 and 40, and these are usually related to mutations in genes such as PARC and LARC. Haven't seen any in Antigua thus far, but I do understand there is one family somewhere around where 3 relatives have Parkinson's disease in the young. So genetics play a huge role.
Thank you very much for that. Our next question is there a downside to putting all patients on extended release carbidopa or levodopa versus immediate release preparation?
I'm not too sure how to answer that question. I mean, when you put them on the immediate release preparations, you may not need the extended release. We usually use the extended release at bedtime, and again with really advanced disease to reduce the motor fluctuations. You know, if they're not having the motor fluctuations, there's really no need to do the extended release. But in terms of true downside, I can't think of any.
Okay, great. And the next question, are there medications that slow the trajectory of the disease process?
That's an excellent question. So this is something that I didn't mention in my presentation, but like we spoke about the alpha-synuclein and the Lewy bodies, you know, being a part of the neuropathology of Parkinson's, and then new drugs that are in phase 1 trials that use to target the alpha-synuclein and the Lewy bodies to help to decrease the progression of the disease. Are we there?
Yes, I'm here.
Okay.
Sorry about that. Okay, thank you for that. And the next question, I think it should be, although rare, are there any specific ways that Parkinson's affect women?
Not specifically. I mean, things to think about, you know, you know, just the same symptoms that men have. And I just think about, you know, the sexual dysfunction, um, mood can be a problem, especially, you know, with fluctuation of hormones. So you have that plus the neurodegenerative side effects of the actual disease. But other than that, nothing specifically where women are affected uh, different to men, so to speak.
Okay, great. That's good to hear. Someone asked to clarify, is DBS available in Antigua?
Unfortunately, no.
No. Okay. So we'll hope for that in the future from our medical
We'll hope
benefit
for that.
formulary committee.
Well, we'll need a neurosurgeon and, you know, all the tools in the operation, in the OT. But what I can say is that I have connections, so I know people. So if there are patients here who may benefit from DBS and can afford it, you know, I can make, you know, pick up the phone and make a call and touch base with some places, and we can organize that.
Okay, we will hold you to that.
Not a problem.
Next question, someone asked, if smoking is what helps Parkinson's disease?
Oh, so cigarettes. This is tobacco. And it's not that it helps it, but patients who smoke are less likely to develop Parkinson's. It doesn't help it.
Oh, okay. Tobacco, use of tobacco. Okay, very good. All right. I saw another question. Besides the increased compliance and cost benefit. Oh, there are any other benefits to CR preparation?
Yeah, so the
What
CR
is your
preparation.
preference?
Yeah, so the CR preparations, you tend to use when you have the motor fluctuations, especially at night, because in the morning you can have disabling dystonias, and by doing a CR preparation at night, you kind of reduce the occurrence of these painful dystonias. My preference is to start with 3 times daily of the immediate release, have the patient do a diary, adjust accordingly. When the motor fluctuation starts, I consider adding the control, well, we don't have it, but this is what I used to do. Add the control release at night. Patient continues to do their diary, and then I adjust the dyskinesias with amantadine, or adjusting the times of the immediate release, and for the off times, if I'm not adjusting them via the adjustment of levodopa, I just add entacapone. So we have an entacapone now, so that would help a lot. But yeah, my preference is to hold on and add the control release later on.
Okay, and I had a question. You mentioned earlier, some persons may have sexual dysfunction. My question would be, those persons who experience sexual dysfunction, if when sent to a urologist, for example, there are no solutions, do you find that you have patients who may cross over to depression due to the inability?
Absolutely, even before, I mean, think about it, is, whether we like it or not, it's still a taboo topic, and patients sometimes hesitate to bring it up. So by the time they do bring it up, by the time they do admit when you ask them about it, it's so late in the game, and they're probably already depressed. They're probably already getting, problems or perceived problems from their spouse. So depression is definitely a huge risk.
Okay, that's something to think about. As you mentioned, most persons would be very shy about bringing up those issues, even to their healthcare provider. Okay, our next question, any specific aerosols and pesticides in our local setting commonly associated with Parkinson's disease, especially with the prevalent use of disinfectant and antiseptic during this pandemic?
Yeah, the only toxin is the MPTP. We don't use that anymore. So there's nothing in your disinfectant or in your soaps or anything at all would increase your risk of Parkinson's. I have heard, however, not since we're talking about antiseptic and disinfectants, that persons who have had COVID um, actually do have a higher risk of Parkinson's, or there have been the emergence of some new Parkinson cases in patients who have had COVID. But I just think this, with the COVID, you have a hit to every system in the body, and the CNS is no exception. So it's just like having a stroke. You just take a second hit by getting an infection or some other thing, and it brings out dementia. So it's not necessary that COVID causes Parkinson's, but there can be an association.
Okay, thank you so much for that. And a question from Dr. Joycelyn Walter Thomas. Excellent presentation. At what stage do you recommend starting speech pathology and physical therapy?
Okay, so if they develop hypophonia, you may want to start to talk about that, or dysarthria. You definitely start with the speech therapy. Always ask about problems swallowing. You can't, I never say dysphagia. You definitely have to use simple words. Ask them about coughing, ask them about choking. patients tend to say no, and then the caregiver or the family member says, oh, yes, that's not true. You do have problems. You always choke, you always cough. So sometimes an accompanying family member is important. So you need to start the speech and language pathology as early as possible. And physical therapy, the moment the diagnosis is made, I send them to physical therapy because exercise is so important.
Thank you so much for that. So all in all, Dr. Osborne, once again, I'd like to say excellent presentation. As you can see in our chat also, the compliments are coming in. I think everyone enjoyed the presentation, quite informative, a lot learned. Even with the repetition, yes, I agree with that. Repetition will make it stick. So a lot learned, very informative, and we do appreciate you taking the time to do that presentation on such a topic that it's rare, but still frequent enough here in Antigua and Barbuda. So gaining the knowledge on this particular disease and how we can treat it and what is available here in Antigua and Barbuda makes a very big difference. And kudos to the Medical Benefit Formulary Committee for having quite a bit of the medications required available here in Antigua for the use of the general public who needs it. Yeah.
Yeah,
Okay.
I'm very pleased about that.
So at this time, it is 11:28 a.m. and we are going to conclude our question and answer segment for our first presentation on the management of Parkinson's disease. And we're going to begin our presentation on the management of epilepsy by Dr. Osborne once again. So Dr. Osborne, you have a heavy plate today, and we appreciate you for it.
It's a pleasure. It's a pleasure once again.
Okay.
So again, during this presentation, I feel like I'm obligated to highlight what Medical Benefits has done. So I'll be highlighting some of the medications that are available through the MBS. I like to have a saying, if my friends know me really well, I usually say that timing is everything. Timing is everything for treatment of Parkinson's. You do the diaries. Timing is everything for headaches. You can determine, if a headache is a migraine, sometimes based on timing. Timing is important for seizures. Time is important for starting seizure meds, stopping seizure meds, treating status epilepticus. Timing is just everything, and I truly believe that. So the management of epilepsy is a really broad topic. And again, just like Parkinson's disease, learning the management of epilepsy takes an entire neurology residency and a clinical neurophysiology or epilepsy fellowship or both, plus years in clinical practice. And I'll do my very best to try to run through some of the points that are important to the non-neurologists and things that will make them think twice about doing some things and things that will make them refer. Trying to advance my slides. So there we go. So I have no disclosures. So here are some people with who have been diagnosed with epilepsy. So we can see here, this is Prince, this is Danny Glover, this is Lil Wayne, it's known as the greatest rapper alive since your greatest rapper retired. He's very poetic. This is Elton John. This is Cameron Boyce. He had epilepsy and unfortunately he died from something called SUDEP, sudden unexpected death in epilepsy. The incidence is 1 in 1,000 and there's several risk factors which include nocturnal seizures, uncontrolled seizures, convulsive seizures, medication non-compliance, vascular diseases like hypertension, as well as sleep apnea. So autopsies are done on these patients and there's no cause for death that's really identified, and we call that SUDEP, all right? It's important to counsel patients on that. Here we have Lewis Carroll. This gentleman wrote Alice in Wonderland. And if you remember Alice in Wonderland, either from your cartoons or from actually reading the book, you'd see that there was some macropsia, micropsia, like seeing things larger than they are, seeing things distorted. And it's believed that the book and the characters were inspired by his epilepsy. So when you have those sort of complex hallucinations, you want to think of the temporal occipital projections, right? These hallucinations. Up in the right-hand corner, this is the great philosopher Socrates, who was believed to have epilepsy. Down in the right-hand corner, you have the great artist Michelangelo. And to the right here, we have none other than Julius Caesar, who is also believed to have epilepsy, versus psychogenic non-epileptic seizures. All right. So when I was preparing for this, I remembered this scene out of Julius Caesar. Julius Caesar, I'm having tongue twisting moments. All right. So the scene is where Cassius is trying to, plot against Caesar, and he's roping in Brutus and Casca. So the conversation starts with Cassius saying, "But soft, I pray you, what did Caesar swoon?" So he's asking, what happened in the marketplace? And then Casca says, "He fell down in the marketplace and foamed at the mouth and was speechless." Then Brutus, like some of us say, "Oh, it is very likely he had the fall in illness. He had the fall in sickness. He has epilepsy." All right. And then Cassius says, "No, Caesar, he had it not. But you and I, an honest Casca, we have the fall in illness." And then Casca says, "I do not know what you mean by that, but I'm sure that Caesar fell down." So when you think about this, yes, he did fall. He did foam at the mouth. And after he had aphasia, all right, he was speechless and he came to. And that sounds like a seizure. But Cassius says no, because, hey, based on the conversations that were happening, he was seeking attention and he faked the seizure, or this was a psychogenic event. Now, this sounds like an ER consultation. This sounds like a conversation with me in the middle of the night or when I come down to the ER and someone says, "Oh, I have a referral for you, it's query seizure." And my questions begin. Who witnessed the seizure? What did the patient do? How long did it last? What exactly happened? How old is the patient? Is there a psychiatric history? Can you really commit to saying that this is a seizure? Whenever a patient has an episodic event or a paroxysmal event, you have to make that binary decision and commit to it, whether or not the patient is having an epileptic seizure, a non-epileptic seizure, or some other non-epileptic event, all right? So definitions, I like to start with definitions. So a seizure is a transient occurrence of symptoms and or signs due to abnormal, excessive, and synchronous neuronal activity in the brain, all right? And this activity happens in networks. No neuron is isolated. Epilepsy is a tendency to have recurrent unprovoked seizures, and based on the 2017 ILAE, International League Against Epilepsy criteria, you can meet the diagnosis of epilepsy by having 2 unprovoked or reflex seizures occurring more than 24 hours apart, having 1 unprovoked or reflex seizure, and the probability of further seizures similar to the general risk of recurrence at about 60% after having 2 unprovoked seizures occurring over the next 10 years. Or you can have the diagnosis of an epilepsy syndrome. You may want to know, like, what is an epilepsy syndrome? Think of the well-defined syndromes that have their specific seizure semiology, their phenomenology, and sometimes an EEG pattern. For example, childhood absence epilepsy starts anywhere between 4 and 8 years old, usually remits by 12, 13, 14 years old. The semiology involves behavioral arrests with staring and sometimes eye fluttering. Very rarely there may be some automatisms. And the events last a few seconds and the patient has no postictal period. That is semiology. And then the classic EEG finding would be your generalized 3 Hz spike and wave activity that augments during sleep. and during hyperventilation. I'm sorry, this poll just popped up. All right. So it's important to classify seizures. Seizures can be of focal onset or generalized. So the meaning of a focal onset seizure is that it originates within networks that are limited to one hemisphere. It may be discretely localized or more widespread. Each seizure type, ictal onset, is consistent with the one from before. So events are stereotypical for each seizure focus, all right? Bearing in mind, patients can have more than one focus, okay? And with each one, you have to describe the semiology of the events. Again, when patients come to you in the clinic and they talk about their seizures and they have their witnesses with them, you have to ask about the semiology. What do you feel before you have a seizure? Or do you even know that you're going to have a seizure? And then you ask the bystanders, okay, what do you see? What do they do? How long does it last? What happens next? What happens next? What happens next? After the seizure, what do they do? Are they tired? Are they combative? Are they confused? What happens? It's really important to note. And if someone has multiple seizure foci, you have to document the semiology for each one. This comes really handy for patients with medication-resistant epilepsy, or the so-called medically refractory epilepsy, which makes up about 30% of persons diagnosed with epilepsy. Okay, it's really important for capturing all of the events in question on scalp EEG, and then to do surgical planning to try to identify the foci in order to decide whether or not you want to do a resection or an ablation, so to speak. Or if you can't do that, you may want to just do neurostimulation, vagus nerve stimulator. All right, so focal seizures can also spread more widely. And, this is your secondary generalization. And we don't call it that, anymore. We usually call it focal to bilateral tonic-clonic seizures, right? It's really important to note whether or not awareness is impaired or intact when classifying the seizures. And then once that's determined, you determine other features such as motor versus non-motor. We'll get into that nauseating detail later. And then further descriptors can be added, such as head version. Patients with some seizures tend to turn their head to one direction. Some patients, the head turn stops somewhere midway. Some, the head version is extreme, and some patients actually rotate. Okay, that's really important. Eye version. So if you're stimulating the frontal eye fields, the Brodmann's area 8, on one side, the eyes will move to the other side, and it helps with localization if that is the initial sign, or it helps with kind of, honing in on the network in terms of the spread, right? Data is important. So scalp data, which is your EEG, the routine EEGs. The video is important. So not only the video EEG recording where we can pause and say, oh, look at this. The patient has a pouting face first, or the patient has these manual automatisms where they kind of play with their chest and play with things around them first, or the patient looks shocked and afraid first. Videos are really important, but we also look at the cell phone videos, which are an increasingly valuable tool for diagnosing seizures, right? MRI, of course. Most of my seizure patients, unless you have a slam dunk childhood epilepsy with central temporal spikes, the so-called, or previously called Rollandic epilepsy or benign Rollandic epilepsy, or BECS. Unless you have that, or childhood absence, or some other thing that may not need MRI, everyone needs an MRI for to help with the seizure classification and to help with characterization and localization. Laboratory data is also important. So, when someone comes into seizure, you want to check the labs. You want to know if they have an infection. You want to know, especially if there's an electrolyte imbalance, particularly with sodium or calcium, sometimes magnesium. Genetic testing can also be supportive. Okay, so awareness during the seizure is defined as the patient being fully aware of themselves and the environment for the entirety of the seizure, even if they can't move. All right, if awareness is impaired at any point during the seizure, it is a focal impaired awareness seizure. So some of the previous terms that you would have heard are the complex partial seizures. And then sometime after that, they call them focal dyscognitive seizures. And now we just call them focal impaired awareness. So with motor onset, there may be an increase of motor activity or a decrease in motor activity. So you can have a tonic seizure where arms may be stretched out and there's muscle contraction for greater than 2 seconds. There can be an atonic seizure where you have loss of tone and you have the so-called drop attacks. So patients may present with a head drop, or patients may actually fall to the ground, and that's a safety issue. There are clonic seizures that involves the jerking of the limbs. All right, you guys have all seen the rhythmic jerking of arms in patients with epilepsy partialis continua. We've had several of these patients admitted, either neurology or medicine, some of which had AVMs, some had tumors, one had HIV with toxo, and these patients just have these focal seizures with intact awareness, and they may have this clonic activity of one limb just going constantly. It either goes constantly for hours or it's acute and repetitive. So it lasts for 10 minutes and then it might stop for a half hour and then it starts again. And that happens for days and weeks and months on end, and it tends to be resistant to medications. So that is, again, is your epilepsy partialis continua or focal motor status. And then you have myoclonic seizures. So myoclonus is a very brief jerk lasting no more than 0.5 seconds or 500 milliseconds. And it can be seen in multiple seizure types. Myoclonus can also be benign. So it's really important to take a history and astutely try to determine whether or not myoclonus is epileptic or non-epileptic. We also see myoclonus in patients who have had return of spontaneous circulation after cardiac arrest. So you have early myoclonus, which is a poor prognostic indicator. So, someone has cardiac arrest and, you get back to circulation and they're comatose and they're not on any sedating medications, but they shouldn't be, really and truly. If you're comatose, you really shouldn't be on midazolam, and they're having random myoclonus, let alone stimulus-induced myoclonus. So sometimes you may be in the room and you happen to sneeze or cough and you realize the patient jumps. That is a poor, that is an ominous sign that, the prognosis for meaningful neurologic recovery is grim. There's also late myoclonus. So for patients who actually wake up after cardiac arrest, they may have myoclonus with action or rest, and it's really, really disheartening and it's annoying, and they drop objects and all that. And that is your Lance Adams syndrome, your late onset post-synaptic myoclonus. And it's really fun, really interesting when you actually deal with these patients. And then you have non-motor onset. So onset can be sensory. So you can, you have patients with positive sensory symptoms such as, paresthesias or crawling sensations in a Jacksonian match fashion, starting maybe from the arms into face into legs or the other way around. This is essentially the ictal discharge marching along the sensory cortex, and it can happen for the motor as well. Then there is, so there's positive symptoms are, the paresthesias or pain. And then you can also have negative symptoms, which you usually see in strokes. But I actually had a patient during fellowship who had ictal neglect, which is a negative symptom. It's the lack of something. And every time they had a seizure, they just, this patient just freaked out and said, I can't feel the left side of my body. During one of the seizures, we actually asked her to draw an object, and she only drew the right side. So it's clear ictal neglect, and it's, that's where physiology and neurophysiology and anatomy comes to life. There are cognitive seizures where someone is doing well, they're high functioning, and then all of a sudden they just forget things, or they lose executive function for a brief moment, and then they may secondarily generalize and realize it's a cognitive seizure. There are emotional seizures that may start with a sense of impending doom, and some of these patients go for years being treated for panic attacks when indeed they're having seizures. And we've had a couple of those during my training. I haven't seen any at Mount St. John thus far, but there are a couple that I've seen during my training where, you know, they've been having panic attacks and they've known themselves for having these palpitations and sense of impending doom and diaphoresis. And then they feel really wiped out after, really tired. And, you know, most doctors were just treating them with antidepressants. And then they went to one doctor who said, hey, you might be having seizures and I feel like we need to refer you to a neurologist, and you may need to come into the epilepsy monitoring unit so we can actually record one of these events, okay? There are autonomic seizures where patients tend to have sweating or vomiting and retching. You can have this in the idiopathic occipital lobe epilepsies. There's a Paniatopoulos syndrome, which happens to be one of my favorite. That is early onset, so it happens in children when they're around anywhere between 6 and 10 years old. These patients can wake up in the middle of the night with prolonged seizure, hemifacial twitching, but they have headaches and this autonomic dysfunction with vomiting. So have a seizure and they vomit, or they vomit and then they have a seizure. It also happens in the late onset idiopathic occipital lobe epilepsy of Gastaut, G-A-S-T-A-U-T, like Lennox-Gastaut. But these patients are a little older. They're anywhere between 14 and 17 years old. The prognosis is usually good. They do well, and some of them remit by their 20s, and some may go on to have refractory seizures, but this is the minority. And then, just like the motor seizures, you can have a behavioral arrest. So in the middle of a conversation, someone stops speaking, they stare, and you know, that's it, that's your seizure. Or they may lose time when you ask them, you know, hey, have you ever lost time and wondered what happened? And, you know, and that may be a, you know, behavioral arrest. All right, so generalized seizures, these are believed to be initiating within and rapidly engage bilateral distributed networks. So sometimes the seizures can appear localized. However, the localization and lateralization are not consistent from one seizure to another. So for those of you who have read my EEG reports and have had patients with juvenile myoclonic epilepsy or some generalized epilepsy, where I say that there were bifrontal predominant spike in wave discharges at 4 to 6 hertz. And this confers an increased risk for generalized seizures. That's the line that I use. I also state that the possibility of a focal epilepsy with rapid bilateral synchrony cannot be ruled out. Because sometimes you can have an ictal onset that spreads almost immediately to the contralateral hemisphere. And for years, these can masquerade as generalized seizures. All right, so motor onset, you can have tonic-clonic and the variants. You can have tonic seizures. You can have atonic seizures, myoclonic seizures, myoclonic atonic seizures, or deuce syndrome, really pronounced DOSA, but spelled deuce. You can have epileptic spasms. So epileptic spasms are seen in infants. There are multiple causes for this, including genetic, metabolic, really infection. I haven't seen any infectious causes, but the spasms occur in two main flavors. So there's a flexor where the trunk is flexed forward and both arms go out, and it lasts approximately anywhere from, by definition, a spasm is from 500 milliseconds to 2 seconds. If it's shorter than 500 milliseconds, it's not a spasm, it's myoclonus. If it's longer than 2 seconds, it is not a spasm, it is a tonic seizure. All right, so we're dealing with 0.5 to 2 seconds. These spasms happen, and they can happen in rapid succession, and it frightens the baby. The other flavor is the extensor, where the arms also go up, baby's eyes open, and then they relax. And again, baby is wondering, what is happening to me? I cannot control this. This is scary. Something's taking over my body. They frequently cry when these happen. The epileptic spasms can happen upon awakening or in transitions from wakefulness to sleep. Interestingly enough, the EEG pattern for epileptic spasms is one of something we call hypsarrhythmia, and it looks something like what you would see a coarse ventricular fibrillation would look like. But during the actual ictal period, there is voltage suppression. It's my mistake to not include the EEG patterns on this as pictures so that you guys can get the visual, but it's really, really fun. And then you have non-motor onset. You have the typical absence that, you'll see the 3 hertz spike in wave activity, where you have an 8-year-old who, the teacher is saying that, hey, Mikey's not really paying attention in class. There's something going on. Grades may be dropping. And when you really take a good history, you realize, listen, this child is having absence seizures, and you do the EEG and you confirm it, you treat it ethosuximide, and it gets better. Typical absence. There's also atypical absence that you'll see in the epileptic encephalopathies like Lennox-Gastaut syndrome. And these tend to be a bit longer. And then the pattern on EEG is not your 3 hertz spike and wave. It's not nice looking at all. It's so slow, 0.5 or 1 to 1.5 hertz, really slow generalized spike and wave discharges. And again, very difficult to treat. It's an epileptic encephalopathy. These patients will be medically refractory. So you have to decide how much you want to sedate them versus how much you want to control seizures. It's okay to live with a couple of seizures and not sedate children too much because quality of life is poor. And then there's your myoclonic absences, where you have myoclonic seizure and absence, and an absence with eyelid myoclonia, the so-called Jeevan syndrome. Also sometimes a little bit difficult to treat, but really important to diagnose because some of these patients, when they become adolescents, it's time for a driver's license, and you don't want to miss these seizures, and 2 seconds can change their lives. Okay, when they're driving, this is, especially if they're driving in the States, they're on the freeway, they're going 70, 80 miles an hour, they have an event, and then that's it. Either they die or live with serious disability. So diagnosis is really important. So epilepsy classification is a multi-level classification framework. There are 3 levels: the seizure type, the epilepsy type, and the epilepsy syndrome. All right, so where possible, you have to hit all 3. Right, so generalized epilepsy, patients have generalized seizure types, and they may have the typical interictal or ictal findings that accompany an EEG that accompany the generalized seizure types, such as the generalized spike and wave. For those of you who have seen EEGs before, you know that the spike and wave discharges do not have to be the same amplitude throughout. They can be bifrontally predominant or more posterior. They can be bi-occipitally predominant or biparietal predominant, but they have to really be bilateral and synchronous, right? So the genetic or idiopathic generalized epilepsy, these are epilepsies with generalized seizures that are associated with the generalized epileptiform EEG patterns, again, such as a spike and wave activity, understood to have a genetic etiology, but not necessarily passed on from parent to offspring. So you'll find physicians use the term idiopathic. We're moving away from that term and realizing that genes play an important role in these epilepsies, and we're calling them genetic generalized epilepsies. Some experts use the term primary generalized epilepsies. That is okay too. Some of them to note are the childhood absence epilepsy, the juvenile absence epilepsy, JME, the juvenile myoclonic epilepsy, and then there's epilepsy with generalized tonic-clonic seizures alone. And what kind of hones you into this diagnosis is that they only have these tonic-clonic seizures, and it happens upon awakening. All right, so you can have a focal epilepsy. So in focal epilepsies, you have focal seizures with or without impaired awareness. EEG findings may be normal, or they may show focal sharp waves or spike waves. And they may also show slowing. So slowing in a particular area of the brain may indicate underlying neuronal dysfunctions, maybe a disruption in a network or the building of a network that may be epileptogenic. This is important. Imaging is important also. Again, when someone comes in with seizures, I want to do a full seizure workup. So I order an MRI. Thank God the MRI is working right now. I'm very happy. We have an epilepsy protocol. Really and truly, the ideal modality is on a 3T MRI, but we have a 1.5. It's a pretty good machine. The quality is good. So, I prefer if all the MRIs for epilepsy workup. And as a matter of fact, for all of the neurological disorders, done here at Mount St. John. Sorry, at Sir Lester Bird Medical Center. You can also have combined focal and generalized, and you'll see this mostly in the epileptic encephalopathies. So Dravet syndrome. So this is an epileptic encephalopathy in childhood. In infancy it starts. Patients may come in with hemiclonic seizures or initially have febrile seizures and then move on to have seizures without fever, the afebrile seizures. And it becomes really intractable. Patients tend to have a mutation in the sodium channel, SCNA1, and these patients do not respond. As a matter of fact, sodium channel blockers tend to worsen their seizures. So you should stay away from the phenytoins and the carbamazepines and the oxcarbazepines. Lennox-Gastaut, again, an epileptic encephalopathy in childhood. The patients with the epileptic spasms can develop West syndrome, which is epileptic spasms, regression, as well as the typical EEG hypsarrhythmia. So most times you hit all three to diagnose West syndrome. And it's important to treat these patients promptly with ACTH or with steroids to try to prevent the progression to Lennox-Gastaut, because it's really debilitating and it takes a toll on not only the patient but the families. So these patients have both generalized and focal seizures. If you don't know, in medicine, it's better to say you don't know than to subject a patient to a diagnosis and render treatment ineffective or toxic. Okay, so if you don't know, you say the onset is unknown, epilepsy classification unspecified. I do not know. It's really important. Until you get help, until you get an EEG, or until you're able to bring the person into the epilepsy monitoring unit or to get a proper MRI. Okay? And in that case, it's important to treat with broad spectrum medications for fear of worsening of paradoxical worsening of a generalized epilepsy with a medication that's used for focal seizures. So epilepsy syndromes, I think I said a mouthful about this already, but while thinking about epilepsy is by the underlying etiology is important. Some may be organized into something that you're commonly seeing and you see regular patterns such as electrical characteristics, clinical characteristics. Again, big example, childhood absence seizures. Really not much to say on this because I spoke about this already. So I won't go through each and every one. This will take forever. It's a whole fellowship, but I just listed these so you can see an example of epilepsy syndromes by age. So the neonatal and infantile syndromes. So it can be benign. You can have so-called quote unquote 5th day seizures or seizures that started, by the 5th day of life. Usually benign. If they go into status, you treat them once with phenobarbital, and some of them just do really well after that. Some don't need treatment. The seizures just remit. There's the early myoclonic encephalopathy. There's Ohtahara syndrome, which the EEG pattern is something called a burst suppression pattern, where there are brief bursts of electrical activity followed by prolonged periods of voltage suppression. And to put things into perspective, this is a pattern that you see when you're treating status epilepticus adequately with propofol or midazolam, or in someone who has had cardiac arrest and a not brain injury. Okay. West syndrome we spoke about, Dravet syndrome we spoke about, epilepsy of infancy with migrating focal seizures. So these patients have focal seizures. Sometimes the semiology is a little bit weird, but the EEG pattern is, dare I say, insane. So typically you'll see some slowing on the EEG, but then seizures will start from one hemisphere and then they stop and start in another hemisphere in another region. You may have 3 or 4 different foci, and they can alternate or go at the same time, and they're definitely bilateral and independent, and very difficult to treat. Patients tend to have a KCN1 mutation. There are also some other mutations that are slipping my memory right now, but the KCN1 are the major ones. And then there's a generalized genetic epilepsy with febrile seizures plus. This also is due to a mutation in your sodium channels, much like Dravet syndrome. To diagnose this, you must have a strong family history. The childhood onset seizures are, tend to be fun to read these EEGs because they have such a nice pattern. The Dusa-Dosa syndrome, epilepsy with myoclonic atonic seizures, myoclonic astatic epilepsy, MAE. There's Givan syndrome, epilepsy with eyelid myoclonias. So you have your seizures, but you also have myoclonic action of the eyelids, and your eyelids tend to shut in a spasmic type of pattern. And again, this is a problem, especially for your quality of life, especially if this a child grows up and wants to drive. You really have to hone in and sometimes bring them into the epilepsy monitoring unit and quantify their seizures. If they're having 3 seizures in the space of 24 hours, okay, not too bad. You're doing okay with your seizure meds. But they're having 50 seizures in 3 hours. That's just not good, and that's poor control, and the risk for injury is high. Lennox-Gastaut syndrome we spoke about, as we also did with childhood absence. There's also epilepsy with myoclonic absences, and the name speaks for itself. We spoke about Paniatopoulos and Gastaut syndrome, which are the idiopathic occipital lobe epilepsies. I believe it is more of a spectrum with the childhood epilepsy with central temporal spikes, or the benign Rolandic epilepsy. So for the childhood epilepsy with central temporal spikes, as the name suggests, it happens in childhood, and EEG shows spikes in the central regions, in the temporal regions, sometimes frontal regions as well. These spikes are augmented during sleep, right? So you may see 20% spike burden during wakefulness, and then they fall asleep, and there come the spikes over and over and over. Now, I'm really anxious to start epilepsy monitoring here, and by that I mean the ability to do continuous, prolonged, long-term epilepsy monitoring. So we do EEG recordings for greater than 4 hours, up to 5 days. And the reason I say this is because sometimes there are some children who, they're born normal, everything, there's no issue at birth, development has been normal, but then they start to do poorly in school, and they may or may not have childhood epilepsy with central temporal spikes. You bring these children in, and you realize that when they fall asleep, not only the spikes are augmented in sleep, or activated, as we say, in sleep, but the burden is as if the patient is in electrical status epilepticus during sleep. The moment they wake up, or the moment there's an arousal, the spikes reduce. The criteria for this is, I think 85% spike wave burden. So you usually start your quantification from the onset of stage 2 sleep, and you take a chunk of the EEG that's 5 minutes, and you count the number of seconds that has at least one spike. And if overall your proportion is 85% or more, then this patient can be diagnosed with continuous spike and wave during sleep. It can also happen where the spike and waves are located mostly in the frontotemporal regions, and these patients tend to have what we call an epileptic aphasia or pure word deafness. And it's a little strange phenomenon where they may not recognize certain tones. So a phone rings and they don't even know that it's a phone ringing in the classic ringtone. And this is called Landau-Kleffner syndrome. And again, it's on the spectrum of continuous spike and wave during sleep. Now, treatment for these involves giving a benzodiazepine at bedtime. And if that works, then the aphasia of Landau-Kleffner improves, and the cognitive impairment of the electrical status epilepticus in sleep also improves. So, these patients tend to do well after that. Sometimes it's refractory and you have to start Keppra, or you have to start carbamazepine, or you may have more than one medication. Some patients are really refractory where you have to do steroids or IVIG, and I've seen it work. And then there's the autosomal dominant nocturnal frontal lobe epilepsies, which has to do with a mutation in acetylcholine channel. And these patients tend to have hyperkinetic seizures where, so you guys know when we look at patients' videos with seizures and we see the staring and the head turn and the tonic activity and the ictal cry and the jerking that goes jerk, 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 and it slows down and then they stop and then they have this snoring. Yes, that looks like a seizure, and you want to say, yeah, that is seizure. But then you have the other patients with their thrashing and pelvic thrusting and moving all around, and you say, nah, that's psychogenic. You have to be very careful because patients with the nocturnal frontal lobe epilepsy tend to have the pelvic thrusting and the hyperkinetic activity and sometimes bicycling of their legs. Again, it only happens at night. But I've been warned by some epileptologist gurus that what was initially thought to be epilepsies that happen solely at evenings, these patients will at one point start to have daytime seizures. And that information comes comes in handy when you're counseling patients about driving. So I once had a patient during my training with autosomal dominant nocturnal frontal lobe epilepsy. And his seizures were characterized by waking up in the middle of the night, kneeling at the side of the bed, getting up, moving his spreads, opening the drawers, fixing pictures, and then he would go right back to sleep. We actually captured it in the epilepsy monitoring unit, and he had ictal discharges during the period, and he was treated with a medication, one of my favorite, lacosamide, and he has done well. All right, so adolescent onset. So there's juvenile absence, which is just like childhood absence, but these children tend to be older. They're myoclonic JME, epilepsy with generalized tonic-clonic seizures alone, autosomal dominant epilepsy with auditory features. So the seizure focus is usually in the temporal lobe around Heschel's gyrus. And then you have epilepsies that happen at any age. They're reflex epilepsies. Whenever you get a chance, if you're bored, you can Google sunflower syndrome. And I don't know if you guys have ever been in a car and you're passing a bunch of lampposts or some other object that's blocking the sun, and you have this sort of photic stimulation, and sometimes these can trigger seizures. There are reflex epilepsies that happen with musicogenic epilepsy, and there's also hot water epilepsy and reading epilepsy. So yeah, these are reflex epilepsies. They're rare, but when identified, they're kind of fun academically. They're progressive myoclonic epilepsies, and then familial epilepsies with variable foci. And you really need an in-depth workup to actually get to these diagnoses. So more recently, we've been diagnosing epilepsy and or classifying epilepsies by their etiology. So there's genetic, there's structural, metabolic, immune, and autoimmune. Like one of my favorites, actually. If you guys saw my opening slide, you'd see that there's a book underneath the clock when I spoke about time, and the book is called Brain on Fire, and it's basically about a news reporter, a journalist from the New York Times who um, who had an autoimmune encephalitis, actually NMDA receptor encephalitis, and the real diagnosis is truly brain on fire. She had some psychiatric syndromes and hallucinations, and it's just an amazing piece of work. Um, it's actually in a movie right now, and I think you can find it on Netflix. So if you're ever bored and you want something to watch, you can search for Brain on Fire on Netflix. Um, she was actually treated and cured by a consultant neurologist from the program that I was. So I'm very proud about that. Their infectious causes. All during training, I was in the States, and they, look at the third world countries in quotations, and they think about neurocysticercosis, and they ask me, "Oh, you see a lot of this, right?" Like, actually, no, never seen a patient. So if any of the more senior physicians or the physicians who have been in practice for us for 10, 20 plus years, if you've seen it, please let me know, because I've never seen a case of neuropsychosis. And then unknown. So let's talk about the management of the first seizure. 10% of the population would have a seizure at some point in their life. So you're allowed to have a single seizure. Of these people, less than 50% will go on to develop multiple seizures. So it's important to do a thorough assessment and to try to help determine the chance of recurrence. And that will help to determine whether or not you treat or you leave it alone. So patients tend to seek medical care after the first generalized tonic-clonic seizure, but it may not be the actual first seizure. You have to take a thorough history and ask about things like, hey, have you noticed that you bit your tongue sometimes when you wake up and not know what happened? Or have you woken up with the bed wet? Did you pee at night and not know why and how and when it happened? Have you lost time? Have you been in conversations or been alone and the time is 2 o'clock and then all of a sudden it's 5 o'clock and you don't know what happened in these 3 hours? You can ask witnesses or family members, hey, are there behavioral arrests? Do they stop during speech? Do they stop during conversations? Ask about myoclonic jerks, particularly in the adolescent and childhood age group. Ask about these myoclonic jerks. Ask them, when you wake up in the morning, does one leg jerk and move out? Or does one arm jerk? Or have you dropped a cup of water or a cup of coffee? Have you dropped your toothbrush in the mornings? These are really important questions and may help you to nail the diagnosis. Recurrent deja vu. So some people have deja vu and it's really nothing. We're fatigued, this phenomenon happens to everyone. But recurrent deja vu, that is just intrusive and it may be the same memory over and over and over. That is concerning for focal mesial temporal lobe epilepsy. Also, jamais vu, being, ask the patients about being in situations or being in places or seeing things that they just don't remember, they haven't remembered before. There are other psychic phenomena like déjà entendu, jamais entendu, but deja vu is by far the most common. And then panic attacks. Again, are these truly panic attacks, or is it an epilepsy arising from the amygdala? So there was a study by Hauser and colleagues that looked at 204 patients after first unprovoked seizure. And the overall risk of a second seizure was 33%. However, after a second seizure, the risk of a third unprovoked seizure was 76%. Right? And most of the recurrence occurred within 1 year. So physicians tend to ask about anti-seizure drug prophylaxis, especially in patients in the ICU or someone who has a brain tumor. So, question is, okay, this person has a GBM, glioblastoma multiforme. Do I just start seizure meds right now? Or there's a cavernous hemangioma. Oh, this patient has a stroke. There's a subarachnoid hemorrhage. Or this patient went for craniotomy for some reason. Do I start seizure meds? And the answer to that is no. There's no evidence that supports that. The only evidence supporting anti-seizure medication prophylaxis is for a high-risk head injury in the early post-traumatic period, that is to say, in the first week, first 7 days. So when making a decision to start a seizure med, you need to decide whether or not your seizure was provoked versus unprovoked. If this patient is an alcoholic and has not had a drink for 4 or 5 days, you may want to entertain a diagnosis of alcohol withdrawal, and they may not need anti-seizure meds. Also drug withdrawal, think of metabolic causes, think of drugs of abuse and other meds. You want to think of the type of seizure. Is this a focal seizure, or is the patient having generalized seizures? In which case your choice of anti-epileptics may change, right? If you're thinking of a childhood absent seizure, you are not going to really want to do Keppra or carbamazepine. Your drug of choice is ethosuximide, and if it's not available, valproic acid. Patient age for obvious reasons, and then acute versus remote symptomatic. So the acute seizures are within 7 days of a brain injury, a stroke, TBI, or a CNS infection. Anything after that will be considered remote symptomatic. So Hesdorf and colleagues did a study comparing 262 patients with acute symptomatic seizures within 148 patients with remote symptomatic seizures. They found that patients with acute symptomatic seizures were 8 to 9 times more likely to die within 30 days compared to those with the first unprovoked seizure, right? After 30 years, however, the 10-year risk of mortality did not differ between the two groups. Over a 10-year period, patients with the first acute symptomatic seizure were 80% less likely to experience a second unprovoked seizure compared to those with first seizure due to a remote cause. This is a graphical representation of what I just said. If it's acute symptomatic, the risk of having a subsequent seizure is low compared to a remote seizure where you see imagery, right? So the risk goes up significantly. All right. So this is a table that I made outlining the type of injury, your risk of recurrence if the seizure is acute symptomatic versus your risk of recurrence if it's unprovoked. So in stroke, the risk of a seizure within 7 days is 33%, but the risk of recurrent seizure if the stroke happened a while back is 71%. So if you have a patient, then it's day 2 of admission and they have a seizure, may or may not want to treat them. Also depends on preference. But if someone had a stroke a year ago or 2 years ago and they're coming in with their first seizure, the quote unquote unprovoked seizure, the remote symptomatic seizure, their risk of having subsequent seizures is 71.5%. Right? So for TBI, it's 13 and 46% respectively. For CNS infections, it's 16 and 63%. So there's a quote in the book, Wiley's Treatment of Epilepsy, which says, and I really like it, through trauma, the brain may be injured by contusion, laceration, compression, and it is well known that these insults may result in epilepsy after a silent period of strange ripening. I like that. The silent period of strange ripening is the epileptogenesis. This is where the networks are being made and the epilepsy focus is being developed. Right? That period lasts for months or years, but these insults produce epilepsy in the case of one individual and not in the case of the other. So not all persons who have had strokes have post-stroke epilepsy. Not all persons who have had TBI have seizures. And it goes on to say that our attention should therefore be directed towards the discovery of this mysterious difference between those who do not develop epilepsy and those who do. Now, the starting seizure medications reduce the risk of a second seizure after the first unprovoked seizure. So there are 2 trials that try to answer this question. So the first one was the first trial, the first seizure trial group. And they studied almost 400 patients aged 2 to 70, 193 of whom were assigned to delayed treatment. The risk of recurrence in the untreated cohort was 18% at 3 months, 28% at 6 months, and 51% at 2 years. So among those who were treated, the risk of relapse was 25% in the first 2 years. So compare that to 51. So this suggests that treatment does lead to a significant risk reduction. This is replicated in the European Multicenter Epilepsy Single Seizure Study, or MES. Yes, it did find that there's that of 408 patients who were randomly assigned to deferred treatment, 26 had recurrence at 6 months, 39% at 2 years. However, at 5 years, 51% of the untreated patients had a recurrent seizures. And then there was further evaluation where Marston and colleagues demonstrated that immediate therapy increased the time to the second seizure. So there's more time to having a recurrent event and to having a first tonic-clonic seizure. And it also reduced the time to remission at 2 years. But at a 5-year follow-up, they found that 76% of patients in the immediate treatment group and 76 of those in the untreated group were seizure-free. So this indicates that the immediate treatment of seizures did not reduce the long-term remission rate in individuals who had a single or who have infrequent uncontrolled seizures. So these are things to take into consideration when you have a patient. They have a prior brain injury or insult. They may have remote symptomatic seizures, and there's a high risk for having recurrent events. If you do the EEG and the EEG is abnormal, more so if they have epileptiform discharges, but slowing can be taken into consideration. If they have a significant brain imaging abnormality, such as an AVM, or focal cortical dysplasia, or some sort of gray matter heterotopia, or polymicrodria, any sort of brain imaging abnormality may be significant. And then if they have nocturnal seizures, so if someone presents to me with a clear seizure out of sleep, that is to say, during sleep, the seizure actually happens, not their sleep, they wake up and then they have a seizure. So again, history is really important. So nocturnal seizures, if you have nocturnal seizures, your risk of having recurrent events is increased. Remember, during sleep, the brain is happy, it's being refreshed and reset, so to speak, and there's a lot of synchrony. Seizures are defined as synchronous abnormal neuronal activity. Let's talk about some anti-seizure drugs, right? So for a couple of centuries, there have been several anti-seizure medications, starting with bromide in the 1850s, and now we're at the third generation anti-seizure medications. Some of my favorite meds are lacosamide and eslicarbazepine and perampanel and brivaracetam. So this is just a graph showing the timeline of when medications came about and how many options we truly have. Okay, so let's start with phenobarbital. So you guys know the mechanism of action. This is just review for most of you. It binds to GABA-A receptors and it prolongs the opening of the associated chloride channels. For those of you taking CAMC or USMLE or any sort of standardized test, you should not miss this, really and truly, especially after today. It has good oral bioavailability and relatively low protein binding. It's metabolized in the liver, it has a long half-life. It is a potent inducer of the P450 system, meaning it accelerates the metabolism of certain drugs, right? It's effective against focal and generalized tonic-clonic seizures, but not against absence seizures, right? The parental formulation is also useful in status epilepticus. So I remember when I started in October of 2019, I had a patient who was in status epilepticus. there might have not been phenytoin available, and I used phenobarbital, and someone wasn't very happy because they said, oh, they know that the drug of choice for status epilepticus is phenytoin. I'm here to tell you the drug to use is the one that you have, and phenobarbital is a good second line treatment after benzos have been exhausted. So the suggested maintenance dose is about 1 to 2.5 milligrams per kilogram per day. It's recommended that you start at 30 or 60 milligrams at bedtime and increase slowly. I'm going to talk about the recommended concentrations because there's really, very rarely is there an indication to check drug levels. Adverse effects, as in most barbiturates, you have sedation, decreased concentration, there's depression, but in children, you can actually have hyperactivity. With long-term use, just like any enzyme inducer, you can have decreased bone density. This is why when you have patients on these enzyme-inducing medications and they're approaching menopause, you need to supplement vitamin D. I haven't seen Dupuytren's contractures, and I haven't seen the plantar fibromatosis and frozen shoulder, but I have heard of them. It's not recommended in pregnancy due to teratogenicity, cardiac malformations, and cognitive problems that can happen. I once did a grand rounds presentation, or you will call it a CME, on women's issues in epilepsy, and it's one of the things that I really love, to the point that we now have a women's and epilepsy clinic here at Celeste Bird Medical Center. So I'm hoping that one day, either the Medical Association or MBS or Medical Council or someone can invite me to do a presentation on women's issues in epilepsy. I'd also like to collaborate with the pediatricians and the OB-GYN doctors to really push this topic. So phenobarbital, we very rarely use it as first-line therapy. Yes, it's here, and yes, I've seen a couple of patients on it. If you've been on it for quite some time and your seizures are controlled and you're not having any cognitive problems and you've been seizure-free for several years, several meaning 10, 15 years, and you're comfortable and you're afraid of withdrawing the medication, then sure, I'll keep it. Otherwise, I really prefer another medication with more favorable side effects. Great for treating status epilepticus, especially in neonates. You give them one dose and boom, it stops the status. It's really great. And my job here today is to highlight all of the good work of the MBS and the MBS Formulary Committee. We have phenobarbital available in 30 and 60 milligram tabs, as well as the 15 milligram per 5 ml elixir. All right, primidone. So not going to say too much on this. Primidone, yes, it can treat seizures. It's converted to phenobarbital. Has a half-life of about 10 to 15 hours. What I really use this for is essential tremor. When I don't want to use propranolol or atenolol. Adverse effects are almost the same as most of the barbiturates. It's sedation, ataxia, dizziness, nausea, vomiting. Really important to start these medications at lower dosages and increase gradually to no more than 250 3 times daily. Phenytoin, a great drug, just not necessarily my favorite, but it's really and truly a good drug. The mechanism of action, it binds to the active state of the sodium channels to prolong the fast inactivation state, and hence it reduces high frequency firing and seizure propagation. Okay, so the normal action potentials continue. If you remember your cell biology and your cellular physiology, normal action potential continues. The high frequency firing is inhibited. The bioavailability is reduced when you are also on calcium antacids and on nasogastric feeds. It's highly protein bound. It's metabolized by the liver. It's a strong inducer. All right. It follows some really nice, well, not so nice kinetics where it's non-linear. So the moment the receptors get saturated, and you add more medication, It rises to toxic levels, and with that, you have the toxic effects of nystagmus and nausea and vomiting and ataxia. And the plan when that happens is to hold the medication. It's reasonable to take the levels, but it's also more important to follow the patient clinically. Once the adverse effects resolve, you can restart the dose at a reasonable dose and consider what you're doing and what you've done to cause this to become toxic in the patient. All right. So there's a protein-free fraction that may increase in patients with renal failure and liver failure, patients in low protein states during pregnancy, and for the elderly. And also in the presence of highly protein-bound meds like valproic acid, because they compete with protein binding. It's effective against focal and generalized tonic-clonic seizures, but it will paradoxically worsen myoclonic seizures and absence seizures, so just be careful. It is not the drug of choice for any generalized epilepsy. So if you're thinking about juvenile myoclonic epilepsy or childhood absence epilepsy, do not use phenytoin. Initial dose is anywhere from 200 to 400 at bedtime. It can be dosed 2 or 3 times daily, depending on the needs. Yes, it is one of the second-line therapies for treating status epilepticus, and it is fantastic. Now I'm going to address a common problem when treating status epilepticus, and this is not specific to Celeste Medical Center alone. It happens at several places around the globe. When someone comes in, an adult comes in with status epilepticus, and you're going to treat with phenytoin or dilantin, as we call it, do not just give a gram. You have to dose it by weight. The treatment for status epilepticus is 20 milligrams per kilogram. So when I see an 80 kilogram person getting a gram, I am just not happy. I wonder why it didn't work or why the seizures become refractory and the patient ends up having to be on midazolam and coming to the ICU. And morbidity and mortality increases. And if we just dose these things correctly, take the time to do a quick calculation, multiply by 2 and add a 0. Okay, with your max dose being 1500, it's important. If you're not going to dose a drug properly, what's the point of treatment? Phosphoenatoin is a water-soluble prodrug. So what happens, we can administer this a little faster, 3 times faster than phenytoin, but you still have to watch out for cardiac effects because it can drop blood pressure, it can cause arrhythmias, sodium channel blocker. We spoke about the adverse effects, sedation, ataxia, dysarthria, nystagmus, diplopia. You'll see that in most of these anti-epileptic drugs. Very rarely, you can have Stevens-Johnson syndrome and toxic epidermal necrolysis. And with long-term use, and this is why I do not like this medication, is gingival hyperplasia, acne, hirsutism, cerebellar atrophy. I have seen this so many times. Decreased bone density because it's an enzyme inducer. You can also have anemia and peripheral neuropathy. So when your patients are being worked with for peripheral neuropathy, you also want to consider, hey, have you been on phenytoin? Are you on phenytoin right now? Maybe we need to transition you to medication with more favorable side effects. It's the most frequently used medication for years. And I have to say again, thank you to MBS and the Formulary Committee. We have 50 milligram chewable tabs and we have 100 milligram XL tabs. Carbamazepine, this is also a sodium channel blocker similar to phenytoin, just good oral bioavailability. It's metabolized to carbamazepine 1011 epoxide, which is an active metabolite. It also carries side effects. It is also a potent enzyme inducer. It also goes through this thing called autoinduction, where it induces its own metabolism. And this results in increased clearance over the first 2 to 4 weeks. There's a shortened half-life and lower serum concentrations. It may accumulate when co-administered with inhibitors. Now, one of the inhibitors in terms of seizure meds that you need to know is valproic acid. But then, grapefruit juice, fluoxetine. I haven't seen anyone on fluoxetine. Like, I don't know if people stop using it. Erythromycin and other macrolides, but not azithromycin. We can use it against focal and generalized tonic-clonic seizures. It will paradoxically worsen absence, myoclonic, and atonic seizures. So do not use it for genetic generalized epilepsy. The recommendation is to start from 100 to 200 twice daily when it's the extended release formulation. I I very rarely do just 100. I just go straight for the 200 twice daily. Patients tend to tolerate it fairly well. It can be increased by 200 every 3 days or so. Side effects, you know it, you should know it by now. You should say it with me: sedation, nausea, dizziness, headache, cognitive impairment. Toxicity can cause blurred vision, diplopia, nystagmus, ataxia, tremor. Long-term effects. So hyponatremia is something that we do see, but not so much compared to its relative oxcarbazepine. Again, it's an enzyme inducer, so there's decreased bone density. There's a risk of leukopenia and aplastic anemia, which happens in 1 in 200,000. So you need to do your CBC. You need to check liver enzymes every 2 to 3 months after initiation, and then maybe every 6 months to a year or so as needed. Stephen-Johnson syndrome, toxic epidermal necrolysis is rare, but it's it's more likely in the Asian population who carry this HLA-B1502 allele. So before starting in a patient with Asian descent, you actually have to test for this allele. You know, might as well you pick another anti-seizure medication because testing will be either unavailable or too expensive. Tegretol or carbamazepine is available through MBS. You have the 200 milligrams immediate release tabs and the 200 milligrams control release tabs. This is the one I use, so I can dose just twice daily, because we all know if you ask a patient to take a medication more than 3 times, they will be non-compliant. There's also syrup, that's 100 milligrams per 5 ml. Oxcarbazepine, unfortunately, we don't have, but it's a structural analog of carbamazepine. It's converted into a monohydroxy derivative with 2 enantiomers. There's S-lecarbazepine and R-lecarbazepine. And what's cool is that S-lecarbazepine was made into another analog of this and called lecarbazepine. And it's dosed once daily, and it's really good for patients who are non-compliant, but too expensive to really push to get on the formulary. And so we can do so of cytochrome 3A4, which is responsible for estrogen metabolism, which means your estrogen-containing pills will be less effective, right? Especially at doses greater than 900 per day. It's effective against focal and generalized tonic-clonic seizures, and just like its friend carbamazepine or its dad or mom carbamazepine, it will paradoxically increase or worsen absence and myoclonic seizures, and should be avoided in generalized epilepsy. Hoping these points are being hit home. Don't just start Tegretol when someone comes in with a seizure, assuming that most seizures are focal and they will respond anyway. It's not a blind shot, it is an intelligent guess. All right, we usually start at about 150 to 300 twice daily, and you can increase by 300 per week as needed. Adverse effects, say it with me: drowsiness, headache, fatigue, diplopia, nausea, vomiting, and hyponatremia. And then the S-lecarbazepine, as I mentioned, the only benefit is that it's once daily dosing. Quite frankly, it's good, but too expensive to even push for it. Next up, valproic acid, the valproic sodium, all right? Mechanism of action, amazing. It blocks sodium channels, it potentiates GABA, and it blocks T-type calcium channels. And this is why it's believed that it can, that it's so good for treating absence seizures. Really and truly, the drug of choice for absence seizures is ethosuximide, but if it's not available or patients can't tolerate it, valproic acid is reasonable. The oral bioavailability is almost complete, which means if you have no choice or no other choice, and if someone is in status epilepticus and they have an NG tube, you can shove it down the MG tube and hope that it stops the seizures. It's a reasonable thing to do. It is a potent inhibitor and reduces the clearance of phenobarbital, lamotrigine, rufinamide, and carbamazepine epoxide. It's effective against all focal and generalized seizures, including absence and myoclonic seizures. So patients with JME, you can treat them as well. Patients with post-anoxic myoclonus after cardiac arrest, you'll see sometimes I will use valproic acid in the treatment of that if we don't have levetiracetam or Keppra. It's pretty good. It's a good medication. side effects may not always be favorable. Okay? Generally start at about 500 milligrams at bedtime. The extended release, I can do 250 twice daily and augment the dose as necessary. And it can be increased as much as 2,000 per day. Adverse effects: nausea, vomiting, anorexia, fatigue, drowsiness. But here comes alopecia, weight gain, peripheral edema, and confusion, right? It's always important when you have a patient with thrombocytopenia to make sure they're not on valproate because it's a rare cause of thrombocytopenia. It can cause PCOS, hyperandrogenism, hyperinsulinemia, and insulin resistance, and may contribute to diabetes and weight gain. I learned this, that it's a reversible cause of Parkinsonism, but I've never seen it. It can cause dementia and brain atrophy. Encephalopathy also happens with hyperammonemia. Hyperammonemia is also more common when you're using valproic acid and topiramate together. So I try to avoid that combination. There's hepatotoxicity, and we all learned about the causes of pancreatitis in school, and valproic acid was one of them. It is highly teratogenic, right? Both cognitive and structural. So when patients come to me and they're a woman of childbearing age, and I realize they've been on valproic acid, I am not very happy to see this. So I try to switch them out, unless it's a situation where they truly plan to not have any more children or not have children. Or of course, if they've had a hysterectomy, then okay, it's fine. I'll accept that. But it's not the drug of choice for women of childbearing age at all. I get really irritated when I see that. I'm sorry. So we do have the tablets. You have the valproic sodium 250 and 500, and we have the sodium valproate 100 milligram crushable tabs, 200 milligram CR tabs, and the 200 milligram for 5 ml syrup. Thank you to MBS Formulary Committee. And now a drug that I pushed for, etosuximide. I'm so happy that it was approved. And we got the email with the list of medications, and it said from after September 30th. So now we're at October 2nd, so the floodgates have opened. So etosuximide blocks T-type calcium channels, metabolized by the liver extensively, fairly long half-life, 30 to 60 hours, and it is the drug of choice for absence seizures. Okay, it doesn't treat anything else but absence seizures, very selective. Starting dose is 250 a day in children who are between 3 and 6. But you can do 250 twice daily if you're older than 6 years old, and increase by 250 per week if needed, with the max dose being 500 3 times daily. And the adverse side effects, for those of you studying for your exams: nausea, vomiting, abdominal discomfort, diarrhea, insomnia, dizziness, fatigue, ataxia. Remember those ad nauseam. There's some idiosyncratic adverse events where you can get a rash, Stevens-Johnson syndrome, a lupus-like syndrome. Very rarely you can get aplastic anemia, thrombocytopenia, agranulocytosis, and even more rare, rare autoimmune thyroiditis. It's now available through MBS in 250 milligram tabs, or in the syrup, 250 milligrams per 5 ml. Clobazam. Thank you, MBS. We now have clobazam, and this is an awesome medication. It is a benzodiazepine. So the benzos are named for their position of the nitrogen atom, and all of the other benzos are 1,4 benzodiazepines. Clobazam is a 1,5 benzodiazepine, and it carries the trade name Onfi, 1,5. And I think that after Cinemet, this is brilliant. It's an excellent broad spectrum drug. It works well for atonic seizures. So, you know, someone comes in, they're on Keppra and Tegretol and whatever else, and they're still medication resistant. You may want to try to add clobazam 5 milligrams twice daily and increase as necessary, and see if that helps. Again, for the drop seizures or atonic seizures, it works well in patients with Lennox-Gastaut. There are patients who, and this comes into history taking, or a patient may just tell you this: hey doc, my seizures, I tend to have seizure clusters around my period. these patients tend to have what we call catamenial epilepsy, and I'll discuss that in my future CME on women's issues in epilepsy. But it's excellent where you can treat with 10 to 20 milligrams around the time of your period, and it really helps for these seizures. There's less tolerance compared to other benzodiazepines and less sedation, and it's believed because of this, that's due to this new position of the nitrogen atoms, the 1,5 position. All right. So again, the adverse effects, drowsiness, but not as much as clonazepam and the others. Nystagmus, there's ataxia, dysarthria, etc. Available through MBS. Thank you very much. 5 milligrams, 20 milligram tabs, and a 2.5 milligrams per ml oral suspension. Lamotrigine. Some persons are afraid of this drug because of the Stevens-Johnson syndrome, but once you titrate this the right way and they get to goal dose and they don't have the reaction, then it's a relatively safe medication. It's really awesome. So it's a sodium channel blocker. The half-life is about a day. Estrogen in pregnancy increases the clearance. So if you have someone who's planning to be pregnant and they're on lamotrigine, you're going to have several follow-up visits, really taking a detailed seizure history. And this is one of the times when it is reasonable to check levels, because the pregnant state will increase the clearance by 50%. So you have to augment the dose prophylactically, so to speak, for lack of a better expression. Caveat with that is that once the patient has delivered, you will have to also decrease the doses because they can become toxic very quickly. Okay. So this is effective against some myoclonic seizures. It can worsen some myoclonic seizures. I've had, I don't have to say good luck, but I've had a good time with lamotrigine for patients with juvenile myoclonic epilepsy where I couldn't treat them with Keppra or valproic acid. It works fairly well. It's less effective for absent seizures than ethosuximide and valproic acid. Requires a slow titration. So the way how I learned it, it takes about 8 to 9 weeks, where you start at 25 milligrams per day for the first 2 weeks, and then increase by 25 milligrams per day each week until you get to a dose goal of 100 milligrams twice daily. And then from there, you can increase by 50s or 100s, and it'll be safe. But once you get to 100 twice daily, you're in the clear, so to speak. And the titration will be half as fast as that if they're on valproic acid, because valproate is an enzyme inhibitor and will increase the concentrations. All right, so the adverse events are dose-related. Again, say it with me: blurry vision, diplopia, ataxia, nausea, vomiting, headache, tremor. So patients who come to you and they have a new tremor and they've been on lamotrigine, it may be the culprit for the new tremor. Rash is seen in about 3% of patients. The incidence of this is higher in persons who have who are being co-administered, who are being treated with valproic acid as well, in children, and patients who their doctor titrated the doses a little faster than they should. Again, there's a rare idiosyncratic reaction in this with Stevens-Johnson syndrome and toxic epidermal necrolysis. There's also hypersensitivity and hemophagocytic lymphohistiocytosis. I have seen this Stevens-Johnson syndrome, but I haven't seen the others. When they were doing the studies for this drug, they found that those who had the rash, the Stevens-Johnson syndrome, were in patients where they started the 100 milligram from jump, right? Most of the patients where you started slowly did not develop this at all. It's favorable. It's one of the drugs that you want to use in women of childbearing age, safe, relatively safe in pregnancy. So I like this for women, as well as Keppra, levetiracetam. Please note, it's available through MBS in 25 milligram tabs and 100 milligram tabs. Topiramate is an antagonist at AMPA receptors. It also augments GABA. It's a weak carbonic anhydrase inhibitor. So For patients who come in with pseudotumor cerebri and I do the lumbar puncture, you remove a high volume of CSF, and I start them on acetazolamide and it doesn't work, I may add topiramate as a carbonic anhydrase inhibitor to help with headache and to help with the treatment. It's metabolized by the liver partially, but 70% is eliminated on change in urine. It's effective in both focal and generalized tonic-clonic seizures. It's a slow titration, but not as slow as lamotrigine. You start at 25 milligrams daily, and you increase by 25 milligrams per week to a goal of 100, and then you can augment to a max of 400 milligrams in BID dosing if you need. Right? Side effects are really important. Yeah, the side effects that you heard me talk about before are important, but this one you need to pay close attention. There's cognitive slowing or fogginess, okay? The trade name for topiramate, or one of the trade names, is Topamax, and it goes by the nickname Dopamax. It makes you feel really slow and dopey and foggy, right? That's one way to remember that. It causes weight loss. I think when they were making zonisamide and topiramate, they initially wanted them to be diabetes medications, and they found that they had weight loss component, and that helped with the diabetes. But then they realized that it helped with seizures and headache prophylaxis, and so it didn't make it for diabetes, but it did for seizures. Patients can have word finding difficulties. There's fatigue and depression. Kidney stones, it's really important to ask about the history of kidney stones because it can occur in 1.5% of individuals. Paresthesias are common, and you also see that with the other carbonic anhydrase inhibitor, acetazolamide. This lasts about 2 to 3 weeks and it goes away. It's not really debilitating at all. Hypohidrosis or oligohydrosis or anhydrosis can happen, and patients can overheat. All right, that's rare. I've never seen it, but it can happen. You're losing bicarbs, so you can have metabolic acidosis. Some patients can have an acute angle closure glaucoma. You'll know that you have this because you'll have intense eye pain and flushing and blurred vision, and it is a pain like no other. I've seen this once. Remember when we were talking about valproic acid, I spoke about hyperammonemia. Again, you can have this with topiramate again when you're using it with valproic acid. The birth defects that can happen are cleft lip, cleft palate, so you want to avoid in patients who are pregnant or planning to become pregnant. It's available through MBS, 25 milligram and 100 milligram tabs. I didn't include zonisamide. I didn't say a lot about it, but it's just like topiramate. It's once daily dosing. I like it for patients who have well-controlled epilepsy, but may be non-compliant because of the one-day dosing and the long half-life. So if they miss a day or two, it will still be in the system and they can catch up. So this is good for college kids who go off to college and now they're up late either studying or doing things they're not supposed to. Levetiracetam. This is your Keppra, and it's one of the most commonly used medications here. It binds to synaptic vesicle protein, so SV2A. There's no hepatic metabolism. 66% is excreted unchanged, and the rest is hydrolyzed to inactive compounds. And no drug interactions. It's a broad spectrum drug, meaning it can treat almost any seizure, focal, generalized, and myoclonic. It's useless for absence seizures, so don't do it. The recommendation is to start 250 to 500 twice daily. I just started 500 daily unless I'm dealing with a very tiny person who's an adult. I may consider starting at 250 twice daily. For children, you want to make sure your medications are dosed by weight. I typically start kids at 10 milligrams per kilogram per dose and increase as needed. For adults, you can increase to as much as 3,000 total daily dose. I don't really see much benefit after the 1,500 twice daily, but some persons do go to the 2,000 twice daily, right? It can be used in status epilepticus, all right? And the dose is not 1,000 milligrams, okay? The status epilepticus loading dose is not a gram, okay? The dose is 60 milligrams per kilogram with the max dose being 4,500. Okay, if someone comes in status and it's refractory to the benzodiazepine and then you give a gram of Keppra, I'm not going to be a happy camper. Okay. Adverse effects, so patients tend to be a little irritable sometimes, especially if they have a history of being quote unquote miserable. If they have a history of bipolar disorder, you may want to think twice about it. Yes, it can cause weakness and somnolence and depression. So you want to ask about suicide ideation. Again, thank you to Janella Jarvis. One thing that we do when we patients come to our clinic is the PHQ-9, which is a depression screen. So if someone had a PHQ-9 score of 0 before and then after they have a high score and they were on Keppra, you may want to consider changing that. Children become hostile sometimes, and we either add vitamin B6. I'm not sure of the mechanism of that, but I've seen it work sometimes. So it's worth a try, vitamin B6 at 100 milligrams per day. Or you can switch to brivaracetam, which is a neuromedication that was FDA approved in 2016. It's similar to levetiracetam. The doses are 10 times less. So instead of a 500 twice daily, it's 50 twice daily. There's less irritability and less hostility, and that's solely why this drug was made. It's now going to be available in IV formulations, and they're studying it to treat status epilepticus, just like levetiracetam. We don't have it yet. Whether it's worth getting, I am not 100% convinced because of costs, and the only benefit is less hostility. You can just change the medication. So Keppra is available through MBS. 500 milligram tabs, 750 tabs, and 100 milligram syrup. Here comes my favorite, or one of my very favorite drugs, nicotinamide. Thank you very much for now putting this on the formulary. So it's a sodium channel blocker, but it enhances slow activation, right? I don't know if there's any neurology residents listening who may be doing the right exam or have the neurology boards or had the neurology boards last week. It's important to know the mechanism of action of this drug, different from carbamazepine and phenytoin, where it enhances slow activation of the sodium channels. It's converted in the liver to an inactive metabolite. 40% is eliminated unchanged in the urine. A 13-hour half-life. Is effective against focal seizures, and new data now supports that it can be used in generalized seizures. The studies really started halfway through my fellowship, and that was just amazing news. Now, it can be used in status epilepticus, and for those of us who don't like to do the calculations of the 20 milligrams per kilogram and the 40 milligrams per kilogram for valproic acid and the 60 milligrams per kilogram for Keppra, it's a straight shot of 400 milligrams one time for lacosamide, and I think that is amazing. We don't have the IV formulation. I'm hoping maybe you guys would allow this to be available sometime in the near future, where we can just hit patients with the 400 milligrams of lacosamide and start the IV 200 twice daily. That works well for status. So for the oral, you start at 50 twice daily or 100 at bedtime. And then after a week, you can increase by 50s or 100. Max dose is about 600 per day, so 300 twice daily. You don't get much benefit after that. Adverse effects include, yes, dizziness, headache, fatigue, nausea, vomiting, sedation, diplopia. What I've seen most frequently is the GI upset, the nausea, vomiting, and the dizziness. It can also cause PR, interval prolongation, so be cautious in patients with cardiac disease and cardiac conduction abnormalities. Thank you, MBS. 50 milligram tabs, 100 milligram tabs, and 150 milligram tabs are available, and you will be getting a lot of SAD requests from me for this. Next drug is perampanel, and this is a nice drug in terms of the name because the name tells you the mechanism of action. So if you look in the name, you see AMPA, okay? It's a selective non-competitive AMPA glutamate receptor antagonist. It's only the oral preparation, extensively metabolized by the liver. It accelerates the metabolism of levonorgestrel, so OB-GYNs pay attention to this. Long half-life, And the adverse effects are, again, ataxia, dizziness, headache, fatigue, blurred vision, right? There is a black box warning, however, for aggression and hostility. And there's stories of multiple people having pyromania, lighting fires, setting things and people on fire. That's not good. Sounds funny, but it's not good. It's effective against focal and generalized seizures as monotherapy for focal and adjunctive therapy for generalized seizures. Really nice medication, except if you have the aggression and the pyromania. All right, so we're talking here about medications and someone not asked about marijuana or cannabis in this day and age. So cannabidiol or Epidiolex, it does not interact with cannabinoid receptor CB1 and does not share the psychoactive properties of THC. So that is to say, you can't get high on this. So the mechanism is really unknown, but it's thought to enhance GABA activity through allosteric modulation of the GABA-A receptor. The bioavailability, I'm not sure of the percent, but it increases when you take high-fat meals. Primarily, it's metabolized by the cytochrome P4 system, the 2C19 enzyme and the CYP3A4 enzyme. Clearance is increased by inducers and decreased by inhibitors. It interacts notably with clobazam. So kind of takes a rides on clobazam's activity. So patients with Lennox-Gastaut syndrome or Dravet syndrome, they should be on clobazam before starting Epidiolex. And if you're in the States, the insurance companies will ask you about what medications the patient is on before giving the clearance for Epidiolex. So you start at 5 milligrams per kilogram, shouldn't be per kg, should be per kg. Per kilogram per day in 2 divided doses for a week, and then you increase to 10 milligrams per kilogram per day in 2 divided doses. Adverse effects include sedation, decreased appetite. That's where that a cannabinoid would cause decreased appetite instead of increased appetite, but there's that. Diarrhea, increase in liver enzymes and bilirubin. So you have to check liver enzymes at 1, 3, and 6 months. And then you can determine how often you want to check it after that. And it's approved for seizures for epileptic encephalopathy. So initially it was just Dravet syndrome and Lennox-Gastaut, but then their epileptic encephalopathy is not otherwise specified and other syndromes, and it's approved for that. Once you can prove that there is an encephalopathy, you can prove multiple seizure types, and you can prove by your EEG report that all of this, that the patients have an epileptic encephalopathy, you will have approval of this drug. All right, so MBS, I wasn't expecting it. I just threw it out there and you guys came through. Thank you so much. 100 milligrams per ml oral solution is available now through MBS. Okay, so cenobamate is a new kid on the block. Its precise mechanism is not known, but it's believed to block sodium channels. It's indicated for focal seizures as monotherapy or adjunctive therapy. And this is somewhat of a wonder drug because you're finding that patients who are previously believed to be medically refractory and just not responding to any medication actually have good control on cenobamate. Right? It requires a slow titration like lamotrigine, and that is to avoid DRESS syndrome, drug reaction with eosinophilia and systemic symptoms. Adverse effects, again, say it with me, dizziness, somnolence, headache, fatigue, diplopia. It's not yet, and I use the word yet strongly, available through MBS. I'm hoping maybe the next time around we can get it. Because I hear very good things about it. I have no experience with it. It's just been FDA approved, but it's a really good drug. So there are other treatments for epilepsy. There's a ketogenic diet. There's a modified Atkins. There's a low glycemic index diet. Ketogenic diet is really strict, and you really need a professional to help you to maintain this. The modified Atkins is less stringent, and you can almost go independent with this. And the low glycemic index diet is even less stringent than the first two. I've seen the ketogenic diet work for patients who come in with super refractory status epilepticus. That is to say, status epilepticus that continues despite the first line, second line, and third line treatment. Patients are then started on a ketogenic diet, and seizures start to remit. So it's amazing. Remember from your biochemistry, GLUT receptors, remember glycolysis and how glucose gets into the cell, and then the hexokinase or glucokinase adds the phosphate and it gets trapped, and it then goes through the pathway of glycolysis to ultimately get 2 net ATP. You have to remember this stuff. You cannot forget your basic science. So the brain uses GLUT1 receptors to get glucose into the cell. And some patients with GLUT1 receptor deficiency tend to have refractory seizures. But if you increase the ketones, the brain can also use ketones for energy, and hence that pathway is reverted, and you have control of your epilepsy. So for medically refractory epilepsy, there's neuromodulation, vagus nerve stimulation. You tend to use this when there's no surgical target or when there's a generalized epilepsy. I mean, you can't cut out both. You can't cut the whole brain out. So use vagus nerve stimulation. It's pretty good. It reduces seizure frequency and seizure intensity and duration by about 50% in individuals. And there are newer systems that have tachycardia detection, and you can change the parameters. You know, I did this quite a bit as a resident and a fellow. Haven't done it since I've been at Mount St. John because we don't have any vagus nerve stimulators here. We don't have any patients with VNS. But yeah, there's the tachycardia detection, and it's thought that if the tachycardia is physiologic, the rate of rise of the heart rate is completely different to if it's an ictal onset from epilepsy, and it's a rapid rate of rise compared to the physiologic component. So there's that. That's how these intelligent algorithms detect these things. There's responsive nerve stimulation, which is a closed loop system. So you implant this device, you put the electrodes at the seizure focus, and not only it sends signals to abort seizures, but it reads information to get the pattern of seizures, and you can interrogate the device and determine the seizure burden, so to speak. Really useful, really neat. Then there's deep brain stimulation, stimulating the anterior nucleus of the thalamus for control of epilepsy, much like you did for Parkinson's disease. And then, of course, there's epilepsy surgery, which is a heavy portion of all epilepsy, of residencies for that matter, in neurology, and epilepsy fellowships. There's a refractory epilepsy conference. It may be called something else elsewhere, multidisciplinary conference or such, but it's the same thing, where they have patients that are deemed to be medically refractory, which is 30% of persons with epilepsy, and they do a pre-surgical workup. You must have at least a couple of scalp EEGs. This is your routine EEG, and you have neuropsychiatric workups, and you have what we call WADA testing, where you go into the angio suite, and there's a neuropsychologist, and we shut down one hemisphere by using a barbiturate. And while this hemisphere is shut down, we test the other hemisphere for language and memory, and then it wears off, and then we shut down the other hemisphere and test the other one. And all of that is trying to determine which areas of the cortex are eloquent, meaning if we take a portion of the brain out, we don't want it to be responsible for memory. We don't want it to be responsible for language. We don't want it to be responsible for hand movement and that kind of stuff. So you have to really be precise with these things. And then there's phase 2, where after you've decided all of this, you've localized on the scalp, you've done your MRIs, etc., you decide where you want to pepper the cortex or the brain with electrodes. So there are grid electrodes that go on the surface of the brain, and there are also SEEG, stereotactic EEG electrodes that are actually placed into the sulci for better recording. And it's just amazing when you have a patient where the electrodes are on the brain and the seizure is happening. The electrical discharges are so pretty. So with that, you decide, hey, seizures are consistently coming from this network and they propagate in such a way. And then with the neurosurgeon and then the epileptologist, the neuropsychologist, and everyone else involved in the care of the patient, you come to a decision as to what type of surgery you want to do. And then patients tend to do very well. One day, I'll be able to give a talk to you guys. Well, I'm able now, but one day I will give a talk to you guys on medically refractory epilepsy or pharmacoresistant epilepsy and all of the treatments and what happens with surgery. It's really interesting. So in conclusion, epilepsy is a complex disease characterized by a tendency to have recurrent unprovoked seizures. History is important. You have to be a little sophisticated when choosing your first line medications. Anti-seizure medications are the first line of treatment, and with knowledge of the pharmacology and knowing your patient well, you can render 50% of patients seizure-free with the first medication and another 20 or 30% with a second medication if needs be. And then other treatments include diet, neuromodulation, epilepsy surgery. And again, these are done for patients with medication-resistant epilepsy. And with that, I'd like to thank you for joining me. Thank you for your patience. I know it was quite a lot of talking.
Thank you so much for that presentation, Dr. Osborne. I see we have a lot of new medication for treatment of epilepsy, and I could hear the excitement in your voice talking about the medications that are now available through MBS. So once again, thank you to the MBS Formulary Committee for providing these medications, because I see Dr. Osborne is very excited. Okay, let's get to questions. One of the first questions from Ms. Denise Williams regarding the COVID-19 vaccine. A lot of patients are seeking clarification on whether they can be vaccinated. And also she added, what about against COVID-19 after being diagnosed with seizure disorder? And if you are willing to do a media session to speak about all of this, addressing the fears of persons who may suffer with seizures and are skeptical about getting vaccinated.
Yeah, so patients with epilepsy should definitely be vaccinated. The International League Against Epilepsy highly recommends the getting COVID-19 vaccinations and state that the risk of getting COVID outweighs the benefit of side effects from vaccination. That is to say, just take the vaccination, you're less likely to have adverse effects, and you're better off doing that than to risk getting COVID, just to be clear. Yes, after the vaccination, you can have an immune response. You can get fevers, and fevers can potentially lower the seizure threshold, and you can have breakthrough seizures. We recommend taking antipyretics, so acetaminophen, paracetamol, Panadol. You take these if you get fever and take them for the duration of the fever, and that will reduce your risk of having breakthrough seizures. Otherwise, there's no contraindications. I've seen patients who've been vaccinated who come in with events, paroxysmal events concerning for seizures, and they're true. And after thorough history and physical, you find out that they're psychogenic. Okay, so there are a lot of stresses happening. People aren't working, school is online. There's a buzz, there's a social media buzz, a little bit positive and a lot of negative things. A lot of things just aren't making sense right now. The decisions that some persons are making are not logical, and it's just a fight down against the whole medical system. And quite frankly, it's frustrating. We're trying to protect people, we're trying to come back to some sense of normality or normalcy, however you want to say it, and just get fought down by these people who are claiming to not be anti-vax particularly, but they are skeptical. And fine, you're skeptical, but at least listen to the experts. You know, the politicians came on and they spoke, and you said, I ain't a politician, why the medical experts, what make them a hide? That's because we're taking care of patients. And you want to hear us? So many have come on board. So many. Dr. Seeley Thomas, Dr. Lester Simon, Dr. Cordner, Dr. Arlene Sorrento, Dr. Eda Hadid, Adrian Rudd. Like, what else do you want? You know, what else do you want? The evidence is proven. I mean, the persons who are really sick and dying hospitalized are those who are unvaccinated. Yes, vaccinated persons do die, but your risk, you need to evaluate their risk. Okay, so persons, my epilepsy patients have been contacting me about the vaccine, and the answer is always yes. I haven't had any person where there's a contraindication. So you definitely should get vaccinated. Got in the media, we can talk about that another time. I'm not sure, to be honest, just being honest with you. It's all exhausting, and we're just saying, everyone is saying the same thing over and over and over. And some people will just not be converted. They're not going to listen. That we just have to accept that. Some people will not listen. So we try to reach the ones that we can change and leave the rest. We can't do any more. How much more? You know?
Thank you so much for that, Dr. Osborne. I will follow up with you and have a conversation with you about that media presentation as the neurologist to reach out, but you and I will talk after at a different time.
No problem.
Okay.
I
We
I sounded pretty frustrated just now, right?
as all of us, I felt where you were coming from. I think all of us are on the same page here. We have a comment and question from Dr. Chanel Joseph to piggyback on what Ms. Denise Williams said earlier. If you could briefly speak on the seizure risk with the COVID-19 vaccines available in Antigua. Well, I think you kind of covered that.
Yeah, I
And
just covered that.
she also mentioned that she had a patient who refused to complete their Pfizer series because she had a seizure about 2 weeks after the first dose and was convinced that it was triggered by the vaccine.
Yeah. So I don't know the specific situation or the patient or what happened with that. When speaking with a neurologist, you always will get the question, well, is this epilepsy? Or is this person having psychogenic non-epileptic seizure and being treated as an epileptic? Was that seizure a response to the stress that they're going through with COVID-19 and now getting a vaccine either volitionally or against their will? I don't know. In terms of it actually any vaccine triggering seizures, I haven't read all of the pamphlets, but the the real risk is the fever, and the fever lowering the seizure threshold. And after 2 weeks, you really shouldn't be having fevers from the vaccine. So I'm not sure about that at all.
Okay, thank you so very much for that. I'm going to ask you to direct your attention to our chat. I don't know if you're following.
I'm looking at say below is a list
Okay.
of some valproic acid containing
Yes.
preparation.
From Mr. Singh, listed a few of the valproic acid containing preparations that we have available in Antigua. And with those that he listed, he wanted to know what factors would determine your choice of preparation and what advice would you give if the preparations are to be interchanged?
That's a tough question. Maybe a question for pharmacology, for the pharmacologist. So the Depakote ER, you can use some doctors prescribe it once daily, but it really should be twice daily. So anything that you don't have to do, that you can do less doses per day would improve compliance, and I just want my patients to be compliant. Depakine is the syrup, I think, and that's good for children who don't want to swallow tablets. Otherwise, that that nothing else really guides my choice per se. And in terms, what is the question? being interchanged. So you definitely need help from pharmacy in terms of interchanging. And, there's a slight difference in the valproate makeup in some of these medications, a very slight difference. And it's reasonable to talk to the pharmacist to understand what the differences are, so you can make your medication adjustment accordingly if the one that you're on is not available. That's as best as I can answer that.
Okay, thank you so very much for that insight. Another question, is there any concern in the data that COVID-19 infection can exacerbate epileptic episodes, active infection, and long-term?
Yeah, active infections, yes. Patients come in and they have this immune response. The wrong term to use is cytokine storm. It's not, it's not really a storm. But anyway, there's this cascade, inflammatory cascade, and that lowers your seizure threshold. And certainly it can, you can have acute symptomatic seizures like we spoke of. Later down, you can have your remote symptomatic seizures. And it's really important because some of these patients can go into status epilepticus, especially if you have an underlying epilepsy that was previously poorly controlled. Okay. Interestingly enough, as I was talking to a group, I was in a WhatsApp group when we were talking about the COVID-19, and we mentioned Guillain-Barré syndrome. And I mean, that's still, the jury's still out on that. But anyway, there have been patients who present with paraparesis and numbness and areflexia. When you do the lumbar puncture, yes, it does show the albumin-cytologic dissociation, meaning high proteins, no cells. But the actual virus has never been detected in the CSF. Never. So maybe with the triggering the epilepsy, it's maybe not direct invasion of the virus, but as a result of the inflammatory reactions and the cascade from these mediators.
Interesting. Okay, we have a comment here, very impressive and in-depth presentations, and someone can attest to you spending a lot of time with your patient and performing very thorough examination. So thank you for that.
You're most welcome.
Our next question from Dr. Jose Velasquez. He mentioned that he remembered you.
Yeah, the panic attacks.
Yes. Panic attacks could actually be epilepsy of the amygdala. And
Right.
is there a way to tell the difference clinically? What would be the ideal drug to treat this situation?
Well, clinically, in terms of the semiology, if it happens the exact way every single time, you want to start to entertain the idea of epilepsy, because epilepsy is a paroxysmal, well, seizures are paroxysmal, and if you're coming from the same focus, then the semiology would be the same every single time, and that's why we document semiology. If a patient is treated appropriately, if you're thinking panic attacks, and you're treating them appropriately for panic attacks, but they still have events, then certainly you want to consider focal seizures from the amygdala or from the mesial temporal lobe period. And the question is there, what would be the ideal drug to treat the epilepsy? Oh, so any of the drugs, so you can choose a broad spectrum drug like levetiracetam or valproic acid, or you can, it's a focal epilepsy, so you can treat with carbamazepine, lacosamide, any of those.
Okay, thank you so much for that. And one of our last questions I see here, what is your take on the use of CBD in the management of epilepsy?
Okay, so we spoke about the cannabidiol Epidiolex that's approved for epileptic encephalopathies. I think I went into detail with that. But you will have patients that come to your clinic who say, hey, doc, when I smoke or when I use a CBD oil, my seizures are less. And that may be very well true. Personally, when I was in fellowship, if the patient had fairly okay control with the anti-seizure meds plus the CBD oil that they got, then I would say, you know what, fine, you, do your thing, but just bear in mind that it's difficult to really gauge how much you're getting in what you're taking. Okay, it's very difficult to gauge. So you may be underdosing or overdosing depending on depending on the case. Also the cost. I mean, I guess now that it's legal, like some people are growing, but the cost may be a bit much compared to your regular anti-seizure meds. Okay. So CBD is interesting, marijuana is interesting, but there's no one cure all because epilepsy is a complex disease from various causes. And you can't tell me that weed is the healing of the nation specifically for epilepsy and specifically for everything else. Doesn't work that way as much as I'd like it to. Okay? But yes, there have been cases where patients use marijuana either by smoking or by the CBD oil, and it really helps with their seizures. And maybe shamefully, but I'll admit it, I'm okay with that.
Interesting response.
Just being honest here.
Thank you very much for the honesty. Okay, Dr. Osborne, I would just like to say again, thank you very much for choosing to spend more than almost half of your day with us this morning, this afternoon.
Yeah.
I can say that we learned a lot from the initial presentation and the second presentation on epilepsy. I see that we have come a very long way in terms of medication management, treatment that is now available. And I am happy to see that you're happy because now you have most of what you need in terms of medication to optimize treatment for your patient. And we look forward to working with you in terms of referrals and getting consults and your opinion on cases that we may have, whether it be in the hospital setting, clinic setting. I know I've reached out to you a few times in the clinic setting and in private practice. So we just want to say thank you so much and to keep up the good work. And we do appreciate you. And I would just like to remind our guests that all of our presentations are being recorded and will be available for viewing on the MBS YouTube channel, website, and Facebook within a few days. So you can look forward to that. Those of you who usually receive my broadcast, once I get that link, I will share it with you for those persons who would like to go over these interviews, and you can share it with other healthcare professionals who may have missed the presentation, and you can share the link with them so they can also catch up and be on the same page with us and learn as much as we did today. Okay, so I would just like to say thank you to all the persons who attended today. I'd like to say thank you to the Medical Benefit Formulary Committee for taking the initiative to put the CME series together, and Dr. Osborne. So now I'm going to turn things over to Mrs. Sharon Butters for our closing remarks.
Thank you, Dr. Stevens. Dear colleagues, indeed, these have been 3 power-packed Saturdays, and we are very grateful that you gave up your personal schedule, your Saturdays, and spent some time with us. You chose to understand some of the very important topics important to medical benefit scheme, to our beneficiaries, to you, the health care professionals, Antigua and Barbuda, and of course, the region at large. it is the intent, the earnest intent of the medical benefit scheme, particularly the MBS Formulary Committee, to maintain, to the best of our ability, a contemporary list with efficacious medications to treat the 11 diseases that medical benefits is responsible for. Those 11 diseases we know are asthma, hypertension, cardiovascular diseases, diabetes, cancer, Parkinson's, glaucoma, mental illnesses, epilepsy, sickle cell, and yes, leprosy. We embark on having some regional specialists who are experienced in their disciplines to present to us such topic of interest relating to our new formulary list. And to them, we are very grateful. Consultants, Doctors Georgette Mead, cardiologist, Kenneth Connell, internist, Dwight Matthias, endocrinologist, Terry Baker, internist, pulmonologist, and to Dr. Gaden Osborne today, neurologist. Again, thank you for your informative presentations. And to you, our audience, we're very grateful to you for your interest and your input. Now, last but not least, I want to thank the MBS Formulary Committee and the planning team for these CME sessions. In no particular order, I'll just quickly mention the names of those persons. Mr. Andre Boville, who is the chairperson of the Formulary Committee and the planning team, Ms. Sandra Jonas, Josina France, Kerry Ann Benjamin, Diana Brown, Naika Walsh, Delicia Bunny, Algernon Roberts, Ian Thomas, Alfred Athill, Dave Bridgewater, Karen Tanis, Sharon Cordner, and yours truly, Sharon Butters. However, throughout the presentations, and you would have heard it mentioned over and over today, presenters were thanking medical benefits for adding such and such to the list. Very important is for you to understand that this committee acts upon your advice. And so what were deleted from the list are what our physicians recommend deletions for to the committee, and what were added to the list are the recommendations from the physicians. So thank you for recognizing that so much was added, and it's only because of you. We encourage you to look out for more prompting from the Medical Benefits Formulary Committee when we will be recommending that you make submissions for additions and deletions to our list. Thank you again. Be aware, however, that this education was for our health professionals, and very soon we shall embark on educating our beneficiaries and our public as to what now Medical Benefits Formulary Committee has added and subtracted. So colleagues, once again, thank you. May you be safe as you go about your life, and may the Lord have mercy on our world. Thank you again.
Thank you so much, Mrs. Sharon Butters, for the vote of thanks and that speech. And we're very grateful to Medical Benefit and the Formulary Committee for all of their hard work and contribution. And we would also like to thank our awesome IT guy here today. He's been here with us all morning for IT support and making sure our Zoom is going very well, clean, fresh internet, all of that jazz. Thank you so much. Mr. Grant. Yes, well, he did mention to me, awesome IT guy. So that stuck with me. But thank you, Mr. Grant, for your hard work. And we can't do anything these days without any proper IT support. That is for sure. So once again, all of our participants, thank you for being here today, this morning. If you're not home, if you're on the road, please be safe. Once again, thank you to the MBS Formulary Committee and those of you who are here today, this morning with me. Thank you for sharing your time Saturday morning with us. And thank you once again, Dr. Osborne, for doing not one presentation, but two important presentations for us today. Thank you so much for doing this.